بسم الله الرحمن الرحيم. الصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I would like to welcome all of you today with this beautiful morning to start the second day of the international conference about mass gathering medicine and emergency medicine. Today we have a group of excellent speakers who they will deliver what we expect as very fruitful scientific presentations. We will start with Dr. Muayyad Al-Badrani. He's an associate professor from Taiba Medical College here in Taiba University. He's consultant in public health, and now recently he is the vice dean, been appointed as the vice dean for clinical affairs in the same college. He's going to speak about outbreak response strategies in crowded settings. Dr. Muayyad, most welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Today, I'm going to present my lecture about outbreak response strategies in crowded setting. So this is my outlines. I'm starting with introducing the topic, risk assessment, identifying potential threats, and pre-events strategies, and then the detection and early warning, containment, then the case management, communication with among the stakeholders, and post-events actions. So the introduction for this topic, which is a mass gathering. The mass gathering are the events that characterized by concentration of people in limited region or specific location, in a specific location. So the example for the mass gathering, like the religious events, sport events, and festival. So the epidemiological importance of the outbreak response is that has the probability for high the probability for transmission risk, because the close proximity increasing the risk for transmission from person to person, and also but it also can potential for rapid amplification once there is infectious agent. So this infectious agent can be escalated quickly among the people who are sitting in the proximity, and also it has the importance on local and global health. So the attendee, it may travel later, so it can transmit the infection even in other countries. And also the resource challenges. There are the crowded setting can constrain the local health care and public health resources. So the risk assessment and preparedness. So if we want to conduct the risk assessment in the crowded setting, so we need to identify the potential infectious threat. Usually we're not just considering the respiratory infections, also the foodborne also can be the factors that can be considered as a potential threats. And also we need to assess the vulnerability. Where is the vulnerability that we can have the issues? We look to the population density. We need to have the calculation for the population density in each areas. And also we need to see the mobility, with also assessing the infrastructure, our capability. We need to know how much we are capable for containment of those infectious agents. And also we look for socioeconomic factors among the attendees. For example, if we have elderly, we have children, we need to look also if we have special risk groups, handicap, and this kind of people we need to consider in our vulnerability analysis. Also the surveillance system, we need to establish the surveillance system before the events. So we have the pre-event surveillance based on the potential infectious threat that we already identified. And also we need to have emergency planning drills and exercise. Those drills and exercise consider within the contiguous plans, and also We have the stockpiling resources that we needed, like antibiotics, vaccination, training and drills, and also we need to consider the coordination with the stakeholders. So when we are looking for the pre-event strategies, usually in mass gathering, we need to consider the health screening and vaccination campaign for vaccination campaigns also, and travel advisories for the people coming from the other countries. So we need to consider the potential threats from certain areas, and also we need to consider the communication and health education for attendee, coordination with a local health and international health authorities, and resource allocation and logistic, like a personal protective equipment for the worker and sanitation program, also the medical facilities to be arranged and ready. We need to test the readiness of the medical facilities at those areas. So when we look for detection and early warning, so we should have the syndromic surveillance. The syndromic surveillance, we need to syndromically monitor the symptoms. So some symptoms we need to be reported by, if it's reported by attendees or staff, and we need to focus on those syndromic surveillance as a case definition for certain cases, and that will be enables early identification of unusual cluster or spike in the illness. So also event-based surveillance, gathering information from a wide range of resources like media reports. We need to see if there is a social media, those kind of portals we need to always under screening, so it can help also for identification, because one of the methodologies that now being used in the social media, which is called the content analysis. The content analysis can help us also to have the information as a part of the screening. Rapid diagnostic tools and point care of testing based on the potential threats. We need to have those rapid diagnostic tests and point of pre-testing. It will be helping for identifying the syndromic and also the event infectious diseases. And also we need to have a real-time collection and sharing digital platform, reporting information, and dashboards. Dashboard usually can be set up as automated dashboard and alert system to inform decision maker and guide operational process, like resource mobilization or targeted screening program for localized area. The containment measure and control measure, everyone know it, the isolation quarantine protocol, environmental hygiene, personal protective equipment, and crowd management and movement control. Sometimes we need to constrain and make some constriction in some areas if there is infectious agent at the crowd setting. Case management and treatment, and my colleague will cover it in detail, triage and clinical management of suspected and confirmed cases, referral system, and we need also to arrange for surge capacity planning. And mental health. Mental health is very important, providing the mental health support for affected individuals. So also we need to establish the communication and community engagement, risk communication strategies, the communication and community engagement. We need also to develop the tailored message for the specific population with their language. Sometimes we need to have the multi-languages information to be spread, and also addressing the misinformation. Usually we need to look for misinformation and rumors, but if we have even screening for those rumors through the social media platform, and we need to engage in community leader and stakeholder so they can help us in the communication and community engagement. Coordination is a ministry here because we have a multi-sectoral collaboration, healthcare provider with law enforcement, people with also public health authorities. Sometimes we need have the communication with the NGOs and also based on the international health regulation, even WHO, sometime in mass gathering to be involved. The post-event, we need also to evaluate our surveillance system if it's well established, and we need to continue monitoring of the our surveillance system, evaluation after action, review for our planning. We need to always monitoring and to see if our planning is effective. And also we need to have always developing lessons and policy recommendation based on our evaluation and monitoring programs. Thank you. This is my resources, and thank you very much.
Thank you, Dr. Maid. Really very useful presentation in the outbreaks. We'll have the question at the end of the session. So we'll proceed with the second presenter, Dr. Abdul Rahman Al-Juwaid. We are happy to have him with us this morning. He is an assistant professor from Taiba University College of Medicine, has the Canadian Fellowship in Emergency Medicine from Ottawa University in Canada, and he's now the consultant in emergency medicine in Medina. He is going to speak to us about the triage systems for mass casualty situations.
Sure. Assalamu alaikum. Good morning, everyone. My name is Abdul Rahman Al-Juwaid. I'm an emergency physician, and as well, I'm an assistant professor, Taiba University Medical College. And my presentation, I'm going to talk about the triage system for mass casualty incident. So by the end of this session, you will be able first to know why triage is different and mass gathering. Then we're going to talk about the core principles of disaster triage. Then we're going to talk, then after that, I'm going to dive deep into the SAR triage system and the modification of the SAR triage when we use it in pediatric. Finally, I'm going to go through the SOL triage system. I'm going to start my topic with this picture, which actually shows a lot of patients in waiting room, either to be triaged or to be seen. If you are the physician in duty, this shift, you are in disaster, and this is not my topic. Actually, we need to find solution, not today. So I know you feel like this, and at the end, we need resolutions. But what I'm going to talk about is not a disaster triage, but is the triage in disaster. First thing, you need to know why it's different, why we don't use the CTAS or the ESI triaging system. The difference here, we have like multiple perspectives. First one is the goal. In your daily shift, when you work in your regular emergency, your goal is actually to providing the best care for each patient. So if you encounter a patient complaining of chest pain, we know that you need to do an ECG within 10 minutes. This is the standard of care. Then if ECG showing STEMI, or as Amal Matou says, occlusive MI, then you need to activate cath lab and proceed with PCI in 90 minutes. So what we are caring about here, one, we need to improve mortality. We care about the mortality as well as we care about the morbidity. We care about how many ejection fraction you're gonna preserve at the end of this occlusion MI. And this is not the scenario in mass gathering incident. In mass gathering incident, we care more about survival rate. So if you are the patient with this chest pain, I'm not going to do an ECG in 10 minutes. I'm going to follow the algorithm, the SAR triage, and if you're turned to be yellow, you're going to be in the delayed care category. This is from goal perspective. Then there is other perspective, like environmental. An environmental perspective, one, if you, in your daily shift, in your regular duties, in your own emergency department, you own it. You know where is the entrances, where there are the exits. You know, the common channels, the pathways, you are familiar with the faces that you are working with every day. In disaster, this is different. One, you're gonna work under stress. Two, it's very chaotic. Three, you're gonna work with people unfamiliar to you. Fourth, you're going to work with non-medical personnel. policemen, firefighters, and so on. So that again, it's a different perspective. Finally, you need to work under stress. Stress and an emergency, it's a controlled environment, so it's that you can mitigate. That's why we have the zones in emergency. Stress and the field, it's gonna feel different, and it's gonna hit different. So here's a recap of what I've just said, why triage is different. One, volume versus resources. Then the main or the core concept, which is the goal shift. So from best care for each patient to the doing the best or the greatest good for the greatest number. So we care more about the survival rate. Then the environment, finally, the time pressure. So the key insight here, daily triage in ER is about priority. Disaster triage at mass gathering is about survival. So from this point, I'm gonna move to, so triage is different. So where we are doing the triage, where in the field is triage performed? So at any incident scenario, usually the field gonna be divided into 3 zones or 3 designated zones. Zone number 1, which is in red here, called the hot zone, where the immediate incident happened. Then after that, there is a warm zone, which is in yellow here, to encirculate the red zone, and actually where the triaging in field happens. Finally, there's the blue zone, or called the cold zone. This is the safest zone among the 3. Plus, it's the place where commander and EMS, transportation, and further EMS operation happens. I'm gonna move to the core principle of disaster triage. So if you want to triage patient in field, you need to go through these principles. 1, it should be simple. And when I say simple or simplicity, it means it's simple at applying it and it's easy to remember it. If you are under stress, I bet you it's gonna be difficult to remember the whole algorithm. So we need a mnemonic. That's why we have 32 can do. Also, we have RPM. R stand for respiration, P for perfusion, then M for mentation. So it's common, we use an ABCs in ER. We use an ABCDE and ATLS. Similar to that, we use a mnemonic for it. Also, it's simple in applying that. So you need an easy and applicable tool. It's not complicated, it's not complex that people gonna stack while they are following it. So you need them to follow it perfectly. This is simple. I'm gonna move to the rabbit. So basically by standards, you need to do a triage. Each patient is gonna take less than 60 seconds, from 30 to 60 seconds. Then we need to ensure safety. Then it should be clear, no ambiguity in it. So this is the START algorithm or START triage. So this is the most widely common used triage system worldwide. So S stand for, or STAR stand for simple triage and rapid treatment. Although it's there is a treatment in it, the only thing that we do is opening the airway. So again, 32 can do or RPM. Then this START triage categorizing people into 4 categories. The first one, red, which is immediate, which means this is life-threatening and but treatable injury. Then we have the yellow category, which is delayed, which means serious injury, but not immediately life-threatening. Then we have green, which means minimal. That means it's a minor injury and patient, it can be delayed or they can go to any walking clinic. Then we have black. Black actually composed of 2 things. 1, diseased or died or arrested. Also, we have expectant. Expectant mean that is unsalvageable. Think under these circumstances, that patient not going to make it. The best example for that, if you encounter a patient in the field, you encounter a patient with 80% total body surface area burn. Are you going to triage him as a yellow, red, or black? Is he going to make it? So this is the common example. Also, if there is a patient with penetrating head injury, but once you follow the protocol of the STAR triage, he's like red. So are you going to choose red? So patient with unsalvageable, who is unsalvageable, or I cannot do that much for him, most likely you're gonna tag him with black. So this is the tag that we use in triage. It has two sides. The front side, also it has the back side. Let me start with the front side. First, there is a serial number in it, and there is a barcode. What we do with that, it's actually resemble the MRN of the patient. So actually we can follow the patient among the whole system through the transportation. So what is the destination hospital? This is the serial number. Then there is many algorithmic decision. So it's a kind of reminder to you how to use it. Then we have the hospital destination, also partial vitals. You have pulse, blood pressure, respiration. And the bottom end, we have the colored tear-off strips. This is where we actually tear off the color to make it visible for each patient. So if he is minor, I'm going to tear nothing. If he is black, I'm going to tear the three colors, or tear off the three colors. Then at the back side, we have a brief medical history, drugs, allergy. Also, we have many personal information. And at the end, again, the color tear-off strips. So the first step of STAR triage is just by checking the ambulation. If the patient is able to walk, then you are going to tag him as a green. So, and they call him walking wounded, not the walking dead, but walking wounded, and you're gonna tag him with green. So why we do that? To clear the field. Then step number 2, we're gonna check on breathing. And when we check on breathing, first we're gonna see if he is breathing or not. If he is not breathing, then you are allowed to open the airway, doing the head tilt or head tilt, chin lift, or the jaw thrust if you suspect a spine injury. If the breathing is resumed, then you're gonna tag him red. If still there's no breathing, then you're gonna tag him black. If this patient is breathing from the first place, then you're gonna count the respiratory rate. If it's between 30 and 10, then you're gonna move to the next step. If it's above 30 or below 10, then you're gonna tag him with red. So breathing turned to be normal. Respiratory rate, let's say 25. You're gonna go to the next step, which is checking perfusion. And by checking perfusion, I mean checking the capillary refill first, not the radial pulse, but the capillary refill. Why we do that? We wanna make sure this patient is not in shock. As you know, the most killer in any traumatic patient is bleeding. So you wanna make sure this patient is not in shock by checking his capillary refill. If it's delayed more than 2 seconds, you should tag him with red. But sometimes you're unable to do that. Let's say burn patient, covered with suits overhand. It's gonna be difficult. Then you're gonna choose the radial pulse. So capillary refill more than 2 seconds, or if there is no radial pulse, you're gonna tag him with red. If the capillary refill is than 2 seconds, or there's a radial pulse, you're gonna move to the next step, which is checking mental status. And we use AVPU. We don't use GCS, we use, if the patient is alert, And by alert, I mean he is talking spontaneously or following command. If yes, you're gonna tag him with yellow, and this is the only scenario he's getting yellow. If he is only responsive with verbal stimuli or pain stimulation, then you're gonna tag him red. If he is unresponsive at all, you're gonna tag him red as well. So this is the flow chart of the STAR triage. I'm gonna just recap to consolidate this concept. So if the patient is able to walk, he is going to be green. Then you're gonna check the RPM. First, respiration. If there is no respiration, you're gonna open the airway. No breathing, then this is diseased, this is black. The breathing resume, he is red. But if there is a respiration from the first place, you're gonna count the respiratory rate. If it's below 10 or above 30, this is red. If it's normal in between, then you're gonna check capillary refill or radial pulse. If there is no radial pulse or capillary refill more than 2 seconds, so means patient in shock, you're gonna tag him with red. If it's normal, then you're gonna go to the mentation. Alert obeying command yellow. Otherwise, it's gonna be red. So START is a useful tool in the field, but it's not Tarrant. We found there is like a common pitfalls in this tool. One related to user execution or human error. The other is the system decision limitation. I'm gonna start with the user execution error. One is the first pitfall, triage inflation. And triage inflation means you are up triaging or over triaging. What does that mean in a simple word? That you are assigning yellow patient to the red zone or to the red category. So as you can see here, so up triaging, assigning more urgent category than the algorithm justify. So why it happens? Multiple reasons. I can classify it into two. One, emotional. So there is a natural fear of guilt once you are the triage officer doing the triage in the field. So there is an intent that you're gonna up triaging the patient because he's like covered with blood. And this is called vividness bias or dramatic injury, someone covered with blood, or there is an obvious deformity. There is a tend that you're gonna triage him up. Also, there is an external pressure. The patient is screaming and he is demanding. You're gonna actually triage him up. And the consequences of this, that you're gonna float the red zone. And by doing this, actually truly critical patients are missed. The second pitfall, which is the under triage. Under triage means that you are assigning critical patient to non-critical zone. So failing to identify critical patients. Why it happens? Because of it's a human error that you are very fast in your assessment. You took less than 30 seconds. So this rapidness that increased the likelihood that you're gonna miss a serious injury. Also misdiagnosing a respiratory rate. We count on respiratory rate. That if you miscount it from 35, that you said it's 25, then you put it as a normal. Then you follow the protocol. At the end, you're gonna tag this patient yellow and he should be red. Then finally, pulse not checked properly. During that disastrous situation, the triage officer might feel his own pulse and mistake it as positive radial pulse. Then I'm gonna move to the system design limitation, which is inherent flaws in the algorithm itself. One is the walking dead paradox. So there is a classic paradox in this triaging tool. By itself, from the first step when we say that walking patient, they tagged with green, that is, we might actually triage people that have a serious or critically or serious injury to the green zone. So let's say someone has an abdominal pain or he is actively bleeding in his abdomen, but he's walking, then you're gonna triage him as a green, and this is a bias. He might collapse there. So CERT first sent all walking patient to the green zone. So consequences, critically injured patient are missed in the initial sort. Then lack of life-saving intervention. And this is the primary criticism to this tool. You do nothing. The only thing that you do in terms of intervention, is just opening the airway. Instead of, like we know, there is a preventive killers, like stopping the hemorrhage, tourniquet it. If there is a pneumothorax, you can do needle decompression. So from this point, the sole triage was created. Then poor pediatric application, because of the parameters, as you know. So the normal respiratory rate for adults totally different than RR and pediatric. So, and this is the reason why the modification happened and Jumpstart created. I'm gonna move to the Jumpstart and talking about the key differences between the Jumpstart, which is in pediatric, and the adult, which is the START. One, again, the first step similar. So before that, you need to know that Jumpstart used to patients less than 8 years, START for 8 years and above. So if the patient is able to walk, yes, then you're gonna tag him with green. Second step, you're gonna check on breathing. If this child is not breathing, then you're gonna open the airway, similar to adult. There is no breathing, then you have to do some maneuver. You need to check first pulse. If there is pulse, you need to give 5 rescue breath. Then you're gonna check on breathing. If he is breathing again, then you tag him red. If there is no breathing, then you're gonna tag him with black. If the patient or the child is breathing from the first place, you need to count the respiratory rate. If it's between 15 and 45, this is normal. If it's above 45 or less than 40 as 15, this is abnormal and you're gonna tag him red. Then the final step, step number 3, checking perfusion. Here you need to check central pulses. We don't do capillary refill. We don't check radial pulse. If there is a pulse, you're gonna move to the next pulse, to the next step. If there is no pulse, you're gonna tag him red. Finally, you're gonna check mental status. Again, we use AVPU, we don't use GCS. And A in pediatric, alertness or alert mean is opening eye and he's speaking spontaneously. Otherwise, there is a response with verbal stimuli or pain, then, or he is unresponsive, then you're gonna tag him red. Again, this is a flow chart, actually explain what I've just said. Let me go through it. Patient able to walk, then he's going to be green, then you're gonna check RPM. Respiration, if there is no airway, you need to open the airway. If he's not breathing, you're gonna check on the radial pulse. You're gonna check on pulse. If he has a pulse, then give 5 rescue breath, then check breathing again. If he is breathing, then red. No breathing, this is black. If the patient has already have a respiration from the first place, then you need to check on that respiratory rate. You need to count it. If it's between 15 and 45, this is normal. You move to the next step. If it's below 15 or above 45, then this is red. Third step, which is perfusion, you're gonna palpate for pulse, central pulse. If it's present, you move to the next step. If it's absent, this is red. Then finally, AVPU. Alert, this is the only scenario where we have yellow, and otherwise it's red. But you need to keep in consideration that infant less than 1 year, sorry, I mean pediatric less than 1 year, we call them infant. They are non-ambulatory, most of them. So you need to keep that in consideration. So for that age group, there is a clinical judgment in it. You need to skip green things, and mostly that patient will end up in yellow. Then also you need to think about the developmental disability. Here is the key differences between START and Jumpstart. So one, if the patient is apneic, in START, you're gonna open the airway. No breathing, tag him with black. In Jumpstart, no, if he's not breathing, you're gonna open the airway. Then if there is no breathing, you need to check pulse. After checking pulse, if there's pulse, you need to give 5 rescue breathe. Then you're gonna check breathing again. Expiratory rate, adult less than 10, more than 30 red, pediatric less than 15, more than 45 red. Pulse check, in adult, you're gonna check the radial pulse. In pediatric, you're gonna check central pulses. Mental status, similar, and ambulation, keep in mind the infant. And this is the START and Jumpstart. I'm gonna talk about the other triage system, which is the SALT, stand for sort, assess, life-saving intervention, treatment, and transportation. So in this triaging system, the first step, you're gonna sort the patient into 3 categories. Any still obvious life threat, you're gonna assess first. Any patient who is waving or there's a purposeful movement, assess second. Then any walking, you're gonna assess third. You're gonna move to the next step, which is assess individual or individual assessment. Then you're gonna do life intervention. So in this triage, you're allowed to do intervention to save life. So if there is a controllable major hemorrhage, you need to control it. You need to open the airway, and if it's pediatric, you need to give 2 rescue breath. If you suspect pneumothorax, you need to do needle decompression. And if there is like chemical or warfare, or there is a chemical exposure, then you need to give an antidote. After doing this, you need to check on breathing. The patient, if he's not breathing, so then that, if there is a breath, then you're gonna move to the next step. COPAIN command or makes purposeful movement, has a peripheral pulse, not in respiratory distress, major hemorrhage is controlled. If yes to all, then you're gonna move to the minor injury only. Is it minor or not? If it's yes, then it's minimal green. If it's not, this is yellow. If there is no to any of these questions in the gray box, then likely you're gonna check on likely to survive given the current resources. If yes, tag him with red. If no, this is black. And that's it. Do you have any question? Thanks.
Thank you, Dr. Abdulrahman Chouaid, very illustrative presentation. I think we will keep the questions till the end of the 3 speakers. We will move to the 3rd speaker today, who is Professor Abu Hassan Abdullah. He was coming to us from Malaysia, Kuala Lumpur, and he's most welcome in Medina. He is the founder head of the Emergency and Trauma Service in the Academy of Medicine in Malaysia. He's also involved in research in stem cell and therapy. And he's also a visiting consultant in emergency medicine in Kuala Lumpur Ministry of Health Hospital. He's going to speak to us. His presentation will be about research and rescue on austere conditions. So most welcome to Prof. Abu Hassan. Go ahead.
Thank you very much. Bismillahirrahmanirrahim. Assalamu alaikum, and very good morning. And thank you very much. It's a great pleasure to be here And again, I must thank the organizing committee and also Dr. Mohammed Al-Fifi for inviting me and to do the sharing. And today, I'd like to discuss with a topic entitled Search and Rescue in an Austere Condition, or what we also term as the combat medic principle. Now, I will give a definition and a terminology that will be interpreted as what it actually means in terms of the component of the topic, the search and rescue, austere condition, and also combat medic. And we will now get to know the features of austere condition and what are the various search methodology and some of the rescue component. And I'll also focus on some of the skill development and training that we have done. And maybe I'll touch a bit on the damage control resuscitation in situation where we need to intervene for life-saving situation in a very high-risk condition. Now, first and foremost, may we just ask ourselves the holistic understanding of the real challenge of major incident and disaster event management. Where are we now? Are we really prepared? We have a lot of theoretical knowledge, but the real challenge of the modern time is we have to deal with the diversity and the complexity of the issue, event, and the incident of this crisis and the major incident of disaster of various type, various situation. The myriad of scenario due to climate changes is also escalating and causing vulnerable human population. The complexity of the crisis, the unpredictability and the vulnerability, the vicinity and all the hybrid situation, the marriage between natural disaster and man-made disaster that have created enormous impact. Now, therefore, we have to stay relevant. We have to be effective and to deal with the rapid evolution and transformation of human life. And of course, as you all probably already know, the escalating technological and human-related crisis that we have war in all over the world, especially in Gaza, and with the use of weapons of mass destruction and so on and so forth. Now let's just get to know the concept of search and rescue in austere condition. Now, search and rescue is a process of to find and to move out a distressed person from an imminent danger. Rescue is the process of moving out patient, a disposition, mobilization with a field of intervention and the treatment of affected patient in that imminent danger area. Now, austere condition, really what we define as the high-risk situation, hazardous, wilderness, remote, and high risk with many, many situations that will develop what high-risk situation, both for responder as well as for the survivors and victims. Now, we have this terminology, which is related to some form like a military culture, what we term as combat medic. The provision of search and rescue in operation of combat or military environment, and the frontliners or the paramedic is to provide trauma medical care, to deploy personnel and or civilian in that combat environment. Now we will have to deal with some of this situation, and the features of the austere condition is as follows. Austere condition refers to a mission of rescue within this very challenging condition and high-risk situation. The situation requires a responder to have a robust, resilient, biological, psychological framework, and special skill to rescue within this challenging situation. Now, as I was saying, austere conditions are very high environment that may endanger both responders and survivors. Hence, special technique, skill must be acquired to do search and rescue in this condition. Now, some of the features of this such a condition, which can describe as an uncontrolled mass gathering, one of it, adverse weather condition, fire with toxic, hazardous chemical material like radioactive material, petrochemical hazard, highly infectious disease situation like COVID, of course, war zone, societal unrest and violence. Now, let's just remind ourselves with this Geneva Convention of Protection. In 1864, European states adopted first ever Geneva Convention to save life and to alleviate the suffering of wounded, sick person in battlefield, as well as to protect trained medical personnel as non-combatants in the act of rendering medical aid. Now, Chapter 4, Article 23 of Geneva Convention states that members of armed forces specially trained for the employment should need arise as hospital orderlies, nurses, and auxiliary stretcher bearers in the search for the collection, transport, and treatment of wounded and sick shall likewise be respected and protected if they are carrying out these duties at times where they come into contact with enemy and fall into their hand. Now, Article 29 reads the members of the personnel designated in Article 25 who have fallen into the hands of enemy shall be prisoners of war, but shall be employed in their medical duties insofar as the need arises. Now, I brought this issue up to make ourselves aware this particular group of individuals who are actually well trained are actually protected because of their special skill, and they can assist in whatever situation. Now, the method and the technique of search and rescue in this situation are plenty, but I will touch on a few to make some association with the response and the principle of the rescue process. Now, Austria Emergency Care, AEC, is a pre-hospital emergency and intensive care that takes place outside normal evacuation framework with limited access to resources and material. The main objective is to reduce morbidity and mortality after serious illness or injury until the patient can be transferred to an appropriate level of ordinary health services. Now, rescue in austere condition, as I was saying, high-risk environment, unstable for responders and victims, for example, fire with toxic gases. And therefore, it is important for us to do risk-benefit analysis. And what will conduct a primary search and rescue and to identify the risk involved and to make a decision whether it's really an effort that can benefit all parties. And the rescue method can be in the form of what we term as hand march, meaning using hand grab and go and drag, or the Rambo rescue, rush in, grab and out. And of course, combat rescue, rush in, minimal stabilization and rescue. Now, of course, we are familiar with the high-risk environment using protected clothing. And of course, in dealing with rescue in austere condition involving fire, at times the fire is not controlled, and therefore we have to wait until the control is done. This is important for us not to create more victim and what we call primum non sere, cause no further harm. Now, high elevation rescue for the rescue agency with using rope and bucket stretcher is an art or skill that have to be learned, and it's not for ordinary responders. Now, the method and technique, again, the principle of emergency care, the time frame is from only about maybe 1 or 2 hours to 7 to 2 hours at most, because it is very challenging, and focus on the recognition of life-threatening condition include the application of emergency care, initial resuscitation, life-saving procedures, initial medical treatment, pain relief is important, and of course, ongoing treatment. The process should involve other personnel like nurses and also paramedics. Now, in combat medic operation, primarily responsible for providing emergency medical treatment within limited primary care and health protection during both combat and also training environment. And let me just remind everyone, actually during training in a combat environment, there are also quite a lot of injuries. Now focus on rapid evacuation process from the point of austere or high risk environment with injury, burn or illness to safety. As I was saying, the process of concept of scoop and run, grab and go or hand march process is a technique that we have to really train. And like I mentioned just now, the biological, physical, mental, resilient, robust framework. Now, they are also responsible for to be creative and to be able to execute the rescue and by their innovation. Now, again, the early advanced intensive care capability in hostile condition at the site, for example, portable ICU capability, have proven to have higher survival rate for seriously ill patients. Rapid evacuation of critical ill, injured patient following initial stabilization is crucial. Focus resources on larger number of less critical patients to rescue more lives. Well, as mentioned by the previous speaker on the concept of the triage to deal with what's the maximum benefit we can get from the process. And of course, there are issues to do with humanistic values as well. Now, it is easily overlooked. Complication of critical care in hostile condition is infections, and therefore control strategies and control environmental contamination from exterior as well as cross-contamination between patients in a crowded condition when basic supplies are limited must be taken into consideration. Now, some of this process, which I'm not going to the detail, but in the framework of things, we have various stages. Now, stage one is very important to organize for the pre-deployment phase. Interpretation of the scenario, determination of the possible clinical syndrome is very important. When we arrive at the site, we must bring equipment or medication that's relevant, and the clinical syndrome assessment is very important. Like we go to the war with the weapon for the right situation. Now, team briefing and the scene size up by the team leader who take role in understanding the whole scenario is important. The team leader must actually define the work process, and we are familiar with this concept of horizontal task distribution, where we'll get the team leader to divide the team into various positions and provide the appropriate care at different part of the ground zero. Now, this is very crucial that the equipment selection in the preparation and safety risk of the rescue personnel and the team attire, the right clothing, and of course, having closed loop communication using communication system is very important. Now, pre-deployment phase is about team coordination and teamwork. And this must be done, and otherwise the process will be haphazard. Now, the primary search, what do you mean by primary search? This is a technique using the spatial intelligence and what we term as situational awareness. And the team leader especially must do a proper assessment. Now, in some ways, there is a special training for the team leader and others, because the responsibility of the team leader have a very significant role in the efficiency as well as the effectiveness of the intervention. Now, as I was saying, prime research is about determining the environment, and if we can rescue someone quickly and take them out for maximum benefit of the rescue process, it should be done. And this can be done by calling out or any whatever process that we can get them out. This is an initial process, it's called the prime research, and it has to be conducted immediately because the environment is unstable and high risk condition. Now, here now we are talking about senses that involve activation of all senses, hearing, looking, and of course, smelling, and all our senses must be sharp to determine, to define the survival location, or otherwise also to define the risk involved. The important aspect, the environment, clues, wherever we can see. And of course, like I said, the triage process must be done just by looking from afar and calling out, and because the high-risk situation may not permit us to go into. Now, the second part of the synthesize up, or what we term as the prime research, include in the confined space or austere condition, we have what we term as self-rescue. Now, this means that if we go in and we define the area is too high a risk for us to continue, we do what we term as self-rescue. We have to get out and save ourselves first, exit without assistance. And then what we call non-entry rescue. In the prime research and in the situational situation, we have to look at situation where we cannot enter at all. And of course, finally, enter to rescue with situation where it has to really define what we can do within that consent. Now, we have heard the previous speaker talking about triage system, and this, of course, have to deal with the method which is a bit more rapid and define the maximum benefit. We can see green patient or whichever the patient that still can walk and run, we get them out as soon as possible. Now, second research, objective triage, is about going in and do to the patient and stabilize and such. I think this is already what we term as the on-site management. Like I said just now, grab and go or hand march or scoop and run is a situation where we take it case by case basis, and environment assessment will be included in determining which process that we can do. Now we have also to learn about hydro rescue, and this is something that's also important. The risk involved not only to the survivors as well as to the responders, and they have to have the skill. Now, we have some situation in Malaysia where there was flood in the hospital. So rescuing patients from a flood in a hospital situation is very high risk. And the patient is not well. And of course, not all responders are able to deal with this situation. There will be panic, and evacuating ventilated patient in an environment like this is very high risk for the responder as well. And there was unfortunate situation in Malaysia where there was hospital on fire. And this is also very difficult situation for us. And there were about 7 casualties. It happens in the intensive care. When it happens in intensive care, the first response was they off the oxygen because it is inflammable gas. And when that happened, the patient on ventilation all will not survive. And there was very high risk situation. So it's a very complicated situation involving many patients with various medical conditions. And I was then elected as one of the person that to do the judgment of whether the process had been done correctly. And it was very unfortunate for us to be able to make decision on our own colleague for what had been done, whether it's right or wrong. So I was the chairman of the investigation. So definitely there was some issues about the rescue process. Now in this situation also, where we have a combination of natural and human technology related disaster, Japan earthquake in a radiation or the nuclear power plant, and of course the rescue was very complicated. So The next part of my lecture is my presentation today is to deal with the skill development. Definitely for this search and rescue in austere condition, only those who are certified. We have to train them specifically for this purpose. So in Malaysia, we have done various skill development and competency training for this purpose. So we have an annual search and rescue exercise and competition that involve teams from all the states, and also we invite from neighboring countries like Thailand, Indonesia, Japan, and they come, though the whole process is about a competition, but more on the exercise, and we give them various scenario, and quite a lot of it is in austere condition. And then we have also a simulation training method, either it's low, moderate, or high fidelity simulation that gives them both an ability to practice mental, emotions, and awareness, and definitely short courses with certification, with various level, basic and advanced of search and rescue in the process of austere condition will also and have been conducted. Now, this is an example of some, I'll share some pictures of our training program, the International Search and Rescue Exercise and Competition. We've done many times every year. Unfortunately, during COVID time, we're not able to continue, and we just started again last year. So this is some of this program that we have. So the concept and the philosophy of the International Major Incident Rescue Exercise and Competition is what we term as the in-depth theoretical knowledge, high-level skill and competency for various situations, especially austere condition, and tactical and technical strategy, multi-agency and multi-sectoral teamwork, humanistic value, and of course, simulation method of skill development. Now we've done in 2011, and this was at the Highland. And then at that time, we have many teams from all over the state as well as neighboring country. And it was very exciting for the young. And then the next year we did in the north of our country in a state called Kedah. And this is at the border of Malaysia and Thailand. So we have many teams from Thailand joining for this competition. And then we went to the East Malaysia in a state called Sarawak. And we have many judges from all over the world as well. We invite from Thailand, from United States, and from United Arab Emirates to be judges to this competition. And they also share their knowledge and wisdom. And we then conduct what we term as the skill training at that time. So we give them opportunity to dress up properly and to develop spirit of competition, and with the skill that they acquire with the 2 or 3 days before that, there will be some pre-exercise and competition training. And of course, last year we had one exercise, and we create scenario like COVID and a few other austere situations. Then this competition has been very popular, and we are planning one very soon. And this time, probably we invite some of you to come over to join in this exercise and competition. And this is very exciting for the young, and they love the ability to gather in like a jamboree situation. And because of that, I also brought this program to Indonesia. And with that, we did it in Bandung, Indonesia. And they call it the Jamboree. I'm a visiting professor of this Universitas Jenderal Ahmad Yani in Bandung, and we created it in a very beautiful forest area, very cool environment, and all the respondents were camping, and then we give them scenario, and they conduct, and we have judges to see their performance. And it has been very successful program. So about this skill development and competency training, short courses with certification have been done, and we actually have the certificate, and only those who have passed this program can be allowed to be in this program or in this response to austere condition. Now, these are some of the technique that we teach them. One man assist, grab and go, and all sorts of processes, and
Right.
2 men carry, and 8 men carry in all sorts of situation. And the other one is some process of intervention, and of course, improvisation of the personal protection safety wear with limited equipment, and improvisation of various intervention, and some training module using different simple item for the rescue purpose. And finally, of course, just to touch a bit on, we also train them on the critical incident stress management and what we term as the acute psychological reaction, or the other name for it is psychological first aid. In all situations, we definitely know that there exists acute psychological reaction. So some of these patients need some assistance, and we actually train them and certify them under the training program called the Critical Incident Stress Management, or CISM, or another name for it, it is psychological first aid. Now, I won't be able to give so much detail into this, but in all disaster management or search and rescue program, psychological first aid, not psychotherapy, psychological first aid must be made aware that in total quality management approach, the important part of the training, rather than physical, biological, and psychological intervention, is also important. But unfortunately, the process of psychological first aid is a technique that has to be learned, and not so simple. And it is not psychotherapy, and it's a process that various phase of intervention. So I just show you some of those terminology that have been used for the training purpose, but we will not have time to go into the specific. So this is very important for everybody to understand, who are involved in this, to understand that CISM, or psychological first aid, is very important for responders to learn and to be able to provide. So we have this short course, and that will be also a certification specifically for this, and it is important for all responders. And finally, of course, quickly, I think some of you fully aware with this, what we term as damage control resuscitation. Now, what we therefore define as the visionary extrapolation of damage control resuscitation. In this situation, when patients are bleeding or something, they deal with a life-threatening condition, the intervention must be done. And at the situation where there will be some high risk, a quick intervention. But there are many interventions that should be done. The appropriate equipment should be used. Now, for example, tourniquet, or the other one is the hemostatic powder, and so on and so forth for bleeding purpose. So I won't be able to get too much into it, but just to mention, damage control resuscitation is also an ability that should be trained for those who are involved in this combat medic situation. Vessel ligation, hemostatic powder. This is a real case anyway, so which I manage in the department. And of course, crash syndrome. How do we deal with the crash syndrome situation? And of course, how do we deal with decompensation process that we have to manage crash syndrome at site? Now, I invented this equipment called the pelvic clamp for the injury to the pelvis. And this is created, there was a patient that have to manage. So anyway, I'm not going to be able to deal with this too much, just to mention to everyone that this process is something that we have to learn, and search and rescue in austere condition is a skill that not to be taken for granted, and it has to be taught and learned. Thank you very much for your kind attention.
Thank you, Prof. Abdullah, for this presentation. We will take questions now for all the three presentations, Dr. Muayyad and Dr. Abdul Rahman. If you have any questions to the speakers, please. Yes, one question there. Go ahead.
Assalamu alaikum. My question to Dr. Abdurrahman, you mentioned in jump triage jump start, if there is no central pulse, it will be red. Why it's not black when the child is having no pulse to the central?
So basically, the question for the online viewers, the question is about the jumpstart algorithm. Actually, he asked if we encounter a patient with no pulse, so what is the next step? Is it black or is it red? So basically, if there is no pulse but he is breathing, that means we need to do something. That's why we tag him with red. Okay.
Any other questions? Yes, Doctora?
Good morning, everybody. It was a pleasure listening for all these talks. I just want to ask about the part of psychological first aid you mentioned in the rescuer part. When you talk about it, do you mean to be directed to the one who's rescuing or to the victims of the event? And how, in short or conclusion, we can apply it in real life? What is the focus of that? Because it's really interesting part for me, since we always ignore the psychological part just for the physical well-being, and then we're gonna go back for the psychological part. We forget the impact of that and the outcome of our action. Thank you.
Yes, very good question, but it's going to be a very long answer. Now, first and foremost, anyway, at this time, it's even at this generation is even more important. Now, this is very important in dealing with a rescue situation, search and rescue situation. There are two different things. First, there is this emotion and feeling that you want to do it, but it has to be matched with the skill and competency. I'm just looking at the recent situation with Fotila going to Gaza. There are many of them who they are very emotive and very emotional and they have a feeling, but that doesn't mean that you have the skill. Now, precisely, I put this topic today to make everyone fully aware that if you ever want to deal with rescue in austere condition, preparation must be done properly. Now, it includes biological, physical ability, resilient, robust, and most important, psychological. Because you have to be very cool. And, you know, our reaction is influenced by hormone. Now, how do we deal controlling our hormone? Now, there is something called the emotional intelligence, empathy intelligence, or empathy quotient, and most importantly, stabilizing our mind. So precisely, the training, we have the skill and we subject them to practice. And then finally, we have something called, we do an analysis of their ability to perform. So I can give another lecture on that, but thank you for the question. And really, I must emphasize, but some of us, unfortunately, involved in the high risk situation, not by planning. So I suppose we have to prepare for that.
Thank you, Prof. Abdullah. We don't need another lecture now, but we will probably have to stop really the questions for the sake of time. I would like to thank all the three speakers, excellent presentations, and we will actually proceed with the second session immediately now. We will not have a break because of the time. So I'm glad to introduce Dr. Abdullah Hawsawi, who is the head of Department of Information and Science and Research Institute of the custodian of the two holy mosques in Al-Qura University. He is well known actually in the crowd management and in the scientific part of the crowd, even in AI. He had some research issues about that and activities helping the crowd management. So we are glad to have Dr. Abdullah with us today, and he's going to speak to us about I think, more introduction in crowd science and management. Dr. Abdullah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Today's talk is going to be about the introduction about the crowd science and management. It's going to be provided by me, Dr. Abdullah Al-Awsawi. The index is going to be the objectives, durations, and certificates, timing, delivery of the course, and materials. So we have this. The module number 1, it's going to be the modeling or the introduction of the, so the definition and mega event and mass gathering and terminology of the course. So here are the definitions. What is the crowd? It's a large gathering and first people at the same physical place at the same time on the century of the sharing the same goal interest. What is the crowd science? It's a body of the knowledge, fact, and truth about the crowd, their behavior, their body of the knowledge, fact, and the trash about the crowd, their behavior, their body of the knowledge, fact, and the trash. Movement and the movement diagnostic. What the crowd management is the practice used to manage and facilitate the crowd activity to ensure their safe security and the enjoyment. And what the crowd control is a practice to use the control crowd when aggregate action had started to. Here is also a mega event in Hajj, how it's going to be or what we have here in Saudi Arabia. A mega event also in Olympics. Mega event which is going in many places. All this is pictures showing you that shopping crash and the terminology. We have here a terminology. What's different between what's crash, stamp, and punish? So the terminology of the crash is a comprehensive force caused by the crowd causing death, which is causing death. Stamp is a sudden freezing, rich, or headlining flights or are of the fence and need people aimed. So panic is a sudden offer things which is fair and with or without coding that reduce. And the crash was a popular of the white face version. So the model 2 is what's called interpret of the crowd science and management. So why, which is increase the safe, why we need this science is to increase the safety standards, reduce crowd accident, reduce fatality and injured of the crowd incidents, better utilize of the resource and infrastructure, enhance user experience during mega event. So crowd disaster, which shows, which is some waves which occurred in mega events. Crowd disaster also shock wave plus panic when people join together sometimes and here crowd disaster also crash how people when they just smash, which is no way those people can survive. Crowd disaster, which is the crash, which is when people they have nowhere to go and the crowd has been becoming oversized. And good crowd management is to find the way that how we can manage or find a way how we can control the movement of those people. Good crowd management, which is, we have to do a good infrastructures, even to be in environment, indoor environment or outdoor environment. So all these lead to these lead us to have a good crowd management. Good crowd management, which is, we have also several ways, which is, to find that. We have also a good crowd management, which is, when we have this kind of information which we can see. Frameworks. How we will do our frameworks usually. We have 4 factors, which is A plus B plus C and D. So we have to control all these factors, which is A is the design of the engineering, and B, which is the communication technology that we used, and C, the crowd management technique that we are going to use, and crowd behavior, which usually is dependent to the event itself. We have sometimes religious events, sometimes we have sports events, sometimes we have music events. So all these we have to be aware and put it in our equations. So, or put it in our plan to know and design all these kind of things. We have first factors, how it's going to be. We have space, and we have information, and we have time, and we have energy. So 4 factors are affecting the population of the behavior of the crowd disasters. So all this we put it together, which is we gather it from the event itself before it occurred. So we have also MDI, which is an ICE, which is RAM, and all these has defined by developed by Dr. Casey Stills, who's we said expert in this field. MID is design, information, and management. ICS is anger and circulation aggressions, and the third one, which is RAM, is route, area, movement, and platforms, which we use usually. So the framework which we use usually, which is we have a location, area, exit, and entry. So the dynamic, which means the people, the dynamic and the movement. So the people, you move dynamically by their movement, so to go to their goals, and crowd and behavior. So how those behavior are moving on this frameworks. So the models, which is 4, is the crowd behavior. We create a crowd profile regarding to the same events, which is age, which we expect to be, ritual events, matures, old people, sports, muscles, event, young, immatures, teenage, and we are gathering also in the social, which is a group, family as individual, group size, gender, which male only or female or only mixed. The psychological is exact, which is the meter we are getting. Also the aggressive, calm and relax of those people. Familiarity with the location and activity that they are doing at the same place. Ethnicity and with the body size, walking behavior, speed, and behavior, education, language, the education level and the language of those people. Let's just take one example of the Hajj environment. You can see most of these profile, which is it's going to apply. But if we have a sport event, so we will detect elderly people, they are not going, they are not there. Elderly people, they are not there. So it's depend on the event itself. We fill this profile about and get some historical data about those people they are going to attend the same event. So we have 7 maths about the crowd, which is irrational, individual in crowd, don't lose rational through, emotional, which is high level of the emotional, is not a result of the crowd image, which is crowd imitation is done by another factor, not by the crowd. We have drift, which is the distraction is even specifics about not related to the crowd. We have suppositions, which is on irrational plus distractives. So we have anonymity, which is related to the event specific is not to be crowded. Informality, which is study, show that the people is the crowd behave indifferently. So during the emergency, what we do module with the crowd measure behaving the competitive and aggressive. So we do pre-testing usually, which is to find this competition how it's going to be, or we test it. Sometimes during evacuation, especially in indoors, we have to get the right size of that door based in engineering. So we know, okay, in this area, we have around 100 person going to be at the maximum. So we have to find best size for the doors, which is while evacuation. So to be sure there is no competitive, no one will harm others while they are evacuating. So we have, there is low competitive and high competitive, but there is some video that I have shared with you to show you some of the competitive, how we are doing this kind of things, which is to reduce the competitives and reduce the injury of those people. Kara look for the information, which is we have a signboard, we have map, we have help desk, we have a stepboard, a phone message, which is one of the more effective use. We have readability. We have also contain useful information, clear, not in boxes. We have a good, which is a good visual sign. We use also, which is different sign, which is to direct those people to their location. We have, which is bad visual sign. Sometimes it didn't give people to the right direction. We have the communication. There is several ways for in mega events or mass gathering, which is to communicate with those people. Mostly people, they use your, they follow your instruction if it was clear what you are saying, especially if you use their language, so you know exactly what they are doing. But here in our environment, especially in Hajj or Haram, which is hard, which is to speak different language, because every 3 months we know we have different visitors, different things. So we recommend most in Haram to use sign, which is popular for most audience or most participant on that location. So discussion seasons, let's just move that one. The model, which is crowd dynamic, how crowd, and we have here also some which is crowd dynamic. Question which is how crowd and pedestrian move, what are the movement pattern and profile. I'll show you something here about shortcut, how people sometimes they create their own move cut to reduce some walking distance. You can see in figures, which is sometimes, which is people they create their own path, which is to use. You can see it in the grass. You can see it different times, which is they don't want to go that way. So sometimes we have to redesign based on the people needs. Self-organized. This is which is some videos which show you which is self-organized. We try sometimes to do some experiment to models, which is, and find the behavior of those people, how they move, how they go, how they behave. Here, lane formattings is related to people, how they behave inside, which is following the lane on formation. So we have aggressives. I have some videos here. Collective movement, pedestrian, while evacuation. You can see here also the low competitives and high competitives. We are targeting here to find the best evacuation time for those people. So we can say if you are evacuating, if you have a place with 100 person in it, this is the minimum size if the door has to be on that location, which is, we compare that minimum time with the saving life of those people. It's depend in the event itself or the evacuation plan which was designed for the event. Improving flow with the obstacles. Sometimes we try to put some obstacles which is in front of the door. It's based on most of the studies say that if you put some obstacles which is in front of the door, so people they can go around. So you are trying not to push all the people inside that door, but something which is to be obstacles, and those people they can evacuate in shortest time. But to do this kind of experiment, it's very difficult. So we use some shapes and ant and mice, which is to do to approve this kind of things. We have, which is also exit choice for the evacuation. Sometimes we do several experiments for those to understand how human evacuate from the building. They follow each other. Sometimes there is herding behavior. Are you going to follow your friends, your family, where your father go, where is your brother go, then you follow him? So all this kind of information, we gather it from this kind of experiment. There is sometimes you go with your family, sometimes you go with your friends. We are trying to see if your friend will affecting your decision while you are choosing the door while we are doing some evacuation. So this is kind of information that we gather from this kind of experiment. This is also a crowd, which is a crowd-like flood. We know sometimes as water floods, they take people from place to another. So same as the crowd, when they come, so they just crash you or harm you. So this is also another experiment. Module 7, which is if inside. So we have designed this, which is based on entry, area, exit, and manage these kind of things based on the location and how many doors that in the location. Crowd density, we get also density is the most important factors. Number of the people related to the area based on the experiment. Safe density for the standard people is 5 people, but in some places, we recommend 4 per meter squares. Walking people need some space. Safe density while for walking people is 3 people, and we have several videos which going to show you how we do that. And more density, more crash and shock wave. So here is the optimum density level. We are trying to we have low risk and high risk. So it's depend on number of the people related with the flow rate and number of the density of the people. This is the way how we control the events. And try also to put all this information, put it in dashboard when number of people increase, so that mean the density increase, so which is risk, that mean increase. So we are in the middle, which is to keep it safe as much as we can. While, let's just give you some example. During prayer time, most the people, they come out from their hotels heading to the harams, but the capacity of the haram is already known. So what the people do in the on the haram area, they try to manage the capacity inside the haram and the road, so to keep the flowing of those people, but with the safe with the safe their lives. So they close those streets which is taking people to the haram itself. We have another example, which is the entry and the exit design. Not applying entry and exit space created. Many people include entry and exit are bottlenecks. Measure performance using the flow rate. Flow rate is the measures as wide multiple time the optimal flow rate. Unit we use, which is people, width, and time. Here is also how we did it, which is with the whites, with the widths of the entrance, and we control the level of the density on those locations. Sometimes we put, which is the bottlenecks, which is you can see it, just to reduce the flow of those people, to keep the movement of those people in the same flow rate. You can see here example also of the density, which increase, which is the density will be if they were two people, how they move. Here is the second example. You can see also for those if they were three people, how their movement speed was effective. This is 3 in 1 meter. This is the picture for if they were 4. Their speed also effective is 1 in 1 meters. Here is if they were 5. Here you see how those people, they move, which is affected density and the speed and their time. So this is, which is an example, which would show you what we did. Here is another, which is, we call it a queue theory. Queuing theory is one of the most important theory in the crowd management we use, which related to one in and one out. Queuing theory, which it has many applicants describe the relation between two variables: arrival, person, time, which have departure rate, person, time unit. We have also queuing theory follow as the cause calculation used to calculate awaiting people in the queuing in the system. An average, we have the average of the waiting time that they be in the system. Sometimes we manage also. We put some rules, which is, you cannot get in unless others came out. So we manage that, which is with the queuing. You cannot go in, go out. This is, we can say in what's called it in books forms. Which is, sometimes we control the entry of those. So we keep people, which is go and we keep people in the waiting area. They cannot get in while the people get out. Here is also the way that how we manage this. This is the fundamental we use also to calculate the queuing links. How people get in, get out. This is the end of my talk today. Thank you so much.
Thank you very much, Dr. Hossawi, for this interesting presentation. Our next speaker is Dr. Asim Al-Hijali. He's an assistant professor of nursing at Taiba University, head Department of Maternal and Child Health Nursing, associate fellow UK Higher Education Academy, Al-Madinah Al-Munawwara. Dr. Asim will talk about empowering healthcare volunteers in mass gathering, a tool for accessing and applying online healthcare information. Dr. Asim, you can start. After this presentation, we will go for breakfast, for the first break, okay, at 10:30, inshallah.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good morning. Hello, everyone. I will start with the idea of that one of the nice things of being in a conference that we all as speakers get to explore the same topic, but with different perspective. My perspective is quite different. It's about the information seeking behavior, and also it's about how to obtain evidence-based health information. So today I will be presenting a topic related to how we can first assess volunteers, and then after that empower them in order to provide and access and to give evidence-based health information. So my topic entitled, it's about empowering healthcare volunteers in mass gathering, a tool for assessing and applying online health information. So first, I would like to start with the idea that mass gathering, we all agree that the mass gathering are important and are unique because it's the diverse and largest population. Yesterday, Prof. Al-Ghamdi mentioned that about the last statistic that we have about Al-Hajj, it's almost about more than 1.6 million. So for that reason, it's considered a unique. And in terms of the volunteers, they are crucial because they are the first one to see and meet the clients, either could be patients or it could be a public member. So actually they are the bridging between the community and between the healthcare teams. And one of the things that might happen in this situation, if a member in the communities have sometimes questions or medical emergencies, or they need to be educated about their conditions. So in this point of view, like if volunteer not trained and don't have enough guidance in order to give evidence-based health information in this situation, misinformation can happen and it can delay care. So what research mentioned there, studies confirm this gap. First, volunteers, as I mentioned, that they are important, but need first to be structured training for them, and also in terms of to have standardized guidance. So the main idea of this presentation, it's how we can prepare volunteers before going to mass gathering in order to allow them to give them the tool that it can help them to find and obtain evidence-based health information, which increase the accuracy of information that we give to community. So I would like also to mention that in terms of the persistence gap in current practice, because our focus here to be systematic, and in order to do that, we have to find information seeking behavior models. And in the next slide, I'm going to mention one of the scoping review that we conducted in order to seek and to scope about the information seeking behavior model exists, and then after that to find what is the best in order to apply for mass gathering. So even though research is available, many tools are not fully integrated into practice because there are different and many reasons for that. Some information seeking behavior models are not fit here in Saudi context, or some of them only focus for specific application or specific context or for specific websites. So adoption is often blocked by, could be low of awareness or limited training, or also time constraint. And as I mentioned that in terms of the usability and contextual fit, what works in other country might not work in the context of mass gathering here in Saudi. So for that reasons, we have to find or to create a tool. This is what we have done in our research. And this tool, we believe that it can help in terms of obtaining evidence-based health information. And there is a term, it's called no-do gap. What does that mean? That means evidence exists, but applying it consistently, it's considered a challenge. And I know that most of you will mention about, okay, what about AI output? What about ChatGPT, Gemini? We are using that now. So what is the issue with that? Recent research had concerns in terms of the using AI output, because some of the volunteers, they don't have enough resources, or they don't have enough expertise in terms of validating the information they obtain. So even research that said that if the information look accurate, when we find it in AI output, that it can mislead. So especially if it's not validated by an expert. So the expert have the idea, he can like verify AI output with medical and credible medical resources. So for that reasons, we need to apply and we need to give volunteers a tool they can use step by step in order to reach to the more accurate health information. So I just want to give you an example that might happen in, for example, in mass gathering. So here is a real world scenario many volunteers face in mass gathering. For example, if a person collapses due to extreme heat, the volunteers here try to help, because you know that it's the nature of the crowding. Sometimes the medical services might be delayed. So for that reason, volunteer tries to help. But search using, for example, as you can see that very broad term like heat stroke treatment, or sometimes the first result was from a blog that it's not no author and no date of publication, also with no credibility. And usually when someone seek for health information, sometimes they pick only the first website, and which consider might be not authentic resources. So if a volunteer take this advice and which was not suitable for mass gathering setting, it might delay care and it might cause some issues with the mass gathering. So the idea, if this situation happened, it might lead to decision-making error, as incorrect advice was applied before the correct guidelines. So I just want to say that also divided this presentation into 3 parts. So the first part, we finish from the introduction and the background and the idea of the mass gathering and seeking health information online, and also with the volunteers. Now I'm just going to talk about the idea of developing the performance tool of seeking health information online. And also we can use think aloud approach or think aloud method in order to assess volunteers before going, for example, to Hajj or any events that consider a mass gathering. So for example, in our study, we developed a tool for assessing the process of seeking health information online think aloud method. And the research team was me and Prof. Heather and Prof. Richard. So we engaged 28 nursing intern students. We use think aloud method. So just to define what is the think aloud method, it's from the name. The think aloud is the method that we ask as a researcher, we ask a participant to verbalize their thought while they are conducting a task. So the main idea of that, because we want to investigate and we want to observe the cognitive process which reflect to find a predict that we can help us at the end. So when you look at the picture, you can see the think aloud method criteria. First, it starts with the identification and issues. For that reason, we have to conduct a scoping review, and our focus was about to find all the information seeking behavior models in order to find what is the strength and limitation in this field. And we find that most of the information seeking behavior model not focusing on the information evaluation or on the real-time information seeking process. So for that reason, we think to use think aloud, and we as a researcher, we have to find a scenario or a skill or a task in order to give it to a participant. So the think aloud method was used. Participant in our study verbalized their thought process while searching for online health information. So they access a variety of resources from trusted medical databases to general search engines. So this gives us a realistic picture of how volunteer may actually search. So our goal in our study was clear: to map their strategic cognitive process for checking credibility and reliability of the information. In other words, we want to see what makes them trust or doubt the information they obtain. So once we finish from our study, we think about, okay, now let's focus on the think aloud sessions, so we can apply this in order to assess volunteers before going to a mass gathering. So the idea of think aloud session, first we need to find a task designed to mimic real situation in mass gathering. For example, in our study, if you look at the table, you can notice that we use patient position, nasogastrotube and contraindication, or Glasgow Coma Scale. Also, we used patient education and ECMO in order to mimic a real situation that allow participants to apply cognitive process as it's on the same time and individually. So in this situation for mass gathering, we can find a scenario related to some scenario that might happen in the mass gathering, like, for example, extreme heat or injuries or hypoglycemia or hyperglycemia. So we can mimic the real patient or situation encounter. Then after that, it's considered a problem-solving approach. It's one of the criteria of Think Aloud method. Then we need also expert collaboration, people who are actually surviving or supervising volunteers in real situation. And then we can reach to the final selection of the statement. So the statement considered here as a task that we need participant will do in order to do the analysis. Then after that, in terms of the actual session, we will start with the task engagement as a real Think Aloud session. Then after that, we will ask the participant to verbalize their thought and cognitive process. So the main idea of that, in terms of the Think Aloud method, we have 3 data sources. Like, for example, in our situation, the first one, it's about the verbatim, when the participant verbalized their thought. And the second one, because we use Microsoft Teams, so we ask participants to share their screen, and then after that, we applied content analysis. We look at what website they enter, what website they ignored, what they highlighted, in order to find a repeated pattern that allow us to create a product, which was the performance tool of seeking health information. And the last part of the data of sources, it's about the note taking. So as I said, that verbalize their thought, then after that we have a warm-up task, one of the criteria of Think Aloud method, and then after that we will ask them to use resources freely and flexible, and we will capture their behavior. So we can conduct that with the volunteers before going to mass gathering, so we can assess them and see what is the strengths and weaknesses in their performance level. So now I'm going to show you some of the example and the results that we get in our studies. And you can see that for the first quotations, an intern mentioned that he knows that the Wikipedia, it's not trusted website because it's adjustable. However, he used the information he obtained from that. So I want to emphasize here, so what about volunteers? So if they have the same idea, are they going to trust unreliable resources? And you know that volunteers, sometimes they could be students, nursing, medical, or emergency students. So they don't have enough experience, and sometimes they rely on online resources. And as I mentioned, that evidence-based practice require utilizing trusted resources, like, for example, in our situation as internal student, they trusted Nurses Lab website. But sometimes cross-checking, it's really important. So to verbalize, also to check the information for more than one source of the information. So this is what we got in our study. The main idea of that It's to create a product, a tool that we can use in our context in Saudi. So the tool we create, it's called the performance tool of seeking health information online. The tool is consists from 17 criteria scoring system. It's like building on the study finding, and we developed a 17 criteria scoring system. The tool is designed for real-time use, and also it aims to improve the information literacy. And also the tool is flexible. It can be used for training modules. It can be used for example, for like individual assessment or self-assessment by the participant, either volunteers or others. And also it can be integrated into official protocol for mass gathering. This is what we aim to, that we have to give them, for example, a short courses on the idea of obtaining evidence-based health information. So I hope it's clear. This is the tool that we end up with. The tool is structured into 4 main domains. The first one, it's about understanding the information needs. Then after that, evaluating source credibility. The third domain, it's about applying the information obtained. And the last domain, it's about confidence and decision making. So I'm trying now to define each one of them quickly. So for example, the first one. So we created this tool based on the Think Aloud protocol. So the Think Aloud protocol, as I mentioned, that it's about the analysis that we get from our study. It consists of 3 parts. The first one, it's about the verbatims. The second one, it's about the share screen and content analysis. And the last one, it's about the note taking. So when you look at the understanding the information needs, so the first one, it's about the interpretation. So is the intern or volunteers able to interpret the health information needs correctly? And then after that, for example, the keyword use creating precise search teams that would help them to direct them to relevance information. And then after that, for example, for the seek clarification, if they addressing unknown words. So for example, if the interns, this is what we see in our study, some of them, when they found unknown word, they just ignore it. But however, some of them, they try to translate it in order to understand the meaning of the context. So it will help them at the end to construct the meaning. And the second part is about evaluating scoring credibility, which is really important part here, because we are talking about patient outcome and patient safety. So we have to evaluate the information that we obtained and find. So in terms of the authorized sources, it means that did they use authorized sources like, for example, Ministry of Health, World Health Organization, NICE, or NHS guidelines. And then after that, about domain check in terms of when they found information, the domain, is it about government or education or just general website? And then after that, about are they going to use medical databases, like for example, CINAHL or PubMed, and also about the author information, the publication date, and also about then after that, applying the information. Are they going to apply information based on one source of the information, or they are going to double check and try to find other source of the information? And the last part, it's about the confidence. So the meaning here, it's step by step, but the more steps that you apply, the more accurate information you might get. And at the end of that, you will be satisfied on the information you obtained. So this is, as you can notice, that it's a published paper. We already published 2 publications based on our study. So if you look at that, is each criteria is clearly defined and scored. And the main idea of that, because it can allow us in order, like it's measurable, and we can do improvable things or skills for participants. So this is an example of our study. I just want you to think about, so what about volunteers? So in our study, when you look at that, you can notice that we have strong performances, we have moderate performances, we have low performances. Our main concern is about the low performances, especially for interns and also for volunteers. In terms of the low performances, if you look at the, for example, medical databases, they got 13%. So When we did that, so we write a recommendation. So this is the benefit of the performance tool. So we write a recommendation that we need to do a short course or training course for participants in order to increase the use of medical databases. So if we do that, we ultimately will say we'll sort out and we will solve the issues for them in terms of medical databases. And then after that, you can look at the percentage of up to date. It's 15%. So it's easily, we can we do short courses for volunteers, and we can and train them how to check the data of the publication. And also about authorized sources, we can train them how to use authorized sources. And you can notice that there is some variation, but overall, the main idea of the performance tool, we can, as educator, we can know that what is the strength and weaknesses, and based on the weaknesses, we can integrate training course for them in order to increase and to solve out these shortages. Okay, so as I said that when we finish our study, we end up with the standardized tool for online health information. Overall, the performance tool, it's a way to evaluate and improve how volunteers search for online health information. It uses 17 criteria checklist in order to be more accurate, find credible and resources, and also relevant. So it's ready to use as we use it in our college, and also it's adaptable to local health protocol and mass gathering. As I mentioned that we already have 2 publications in this topic, when it's 2029 and when it's 2024. And also we have 3 articles under publication, 1 of them under publication, 2 of them it's under data collection phase. So we recommend actionable steps. This is the main idea. We have 2 things. The first thing, we can assess volunteers by doing think aloud, or we can use the performance tool and we can ask them to self-assess, to do self-assessment. Based on that, we can do actionable step. So we recommend actionable step. In our example, to integrate databases, courses like PubMed, Medline, and CINAHL. And I know that sometimes we don't have access, but it's really important to know that we should use medical databases, and also engage them in critical thinking exercise. It's really important, especially on the part of the information evaluation. So critical thinking exercise, clinical reasoning, consider one of the important part of evidence-based practice. And also we need to train ourselves as educator to mentor volunteers in evidence-based searching, and also in general, because you know that nowadays the information, especially the health information, it's increased massively. And sometimes students or volunteers access to find health information online, but we need to educate them how they can find reliable and authentic resources, and also develop self-assessment tool to encourage independent learning. And finally, integrate this tool as a short course before Al-Hajj, for example, or Umrah or national events orientation. So we can allow and we can add more value to volunteers in order to obtain evidence-based health information. So in conclusion, access to online health information alone is not enough. The real challenge is teaching volunteers the skills to evaluate and apply. So right now, the gap is clear for us. Volunteers sometimes prioritize speed over accuracy, or sometimes they access unreliable resources. So what is really important here, it's about the accuracy of the information, because this is what saves lives. And the performance tool provides a structured, evidence-based solution that balance speed with safety. So by empowering volunteers, they could be nursing, medical, or emergency, to act with confidence, clarity, and credibility. So by empowering volunteers, we believe that we ultimately protect the communities. And this is the references, and thank you so much for your listening.
Thank you very much, Dr. Asim. I think we should go now for a break. If you have any question for the speakers, you can ask them during the break. Okay, you can join them or talk to them anytime during the break. We will make the break for 15-20 minutes so we can finish early today. Is that okay with you? So we'll come back after 20 minutes. يعني تقريبا 50. Okay, 10:50. Okay, 10:50 we'll start sharp. Dr. Mazen will start at 10:50. Thank you very much.
Shamrani, Associate Professor of Computer Engineering and Advanced Technology at Al Qura University and custodian of the two Holy Mosque Institute for Hajj and Umrah Research Center in Mecca. He will be presenting on AI-driven system for continuous remote monitoring of vital signs in elderly and disabled population.
طيب بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وأصحابه أجمعين. I'm going to speak about the revolutionary implementation of services during Hajj mass gathering based in AI solutions. So one of the main concerns now that we have in Hajj big events is elderly people and also people with disabilities. Those two kind of customers, users, service, or people that need services are much concerned about different type of needs, different type of implementation, different type of how to serve them and let them enjoy the experience in a healthy and good shape and good and better way of service during mass gathering or huge events like Hajj, Umrah, and even sports events. So one of the main concerns is how to employ what we can provide for them based on technology. This will lead us to a solid background about the aging population that creates being created during current state of services. So each year we receive in Saudi Arabia a huge number of pilgrims. 60 to 65% of them are over 60 years. So imagine that we have most of the people who are giving their our services are elderly people. Elderly people are concerned as one of the most related type of people in Hajj and Umrah, especially in last few years. And we have a clinical based elderly care insufficient to care about the service provided them, because the ability to have health problem for this type of people are higher than young people or younger generations. Continuous monitoring that needs for this type of people. That's why we need to have an early detection to prevent any worst case scenarios. Each year we, for example, in Mecca, we provide heart surgeries for about 500 Hajji each year in Mecca, as an example, as this is an average. So we need to detect any worst case scenario before it's happened. This is the aim of this paper, to employ what we can collect of data to prevent the worst case scenarios in huge events. As you can see, the population of the elderly people are coming higher and higher. The average age, for example, Saudi Arabia jumped to 75 or 80, I think, I remember, in the last 2 or 3 years. It's expected to reach about 86 or 87. So we are speaking about a huge number of people that we're gonna, inshallah, we will be in this age sooner or later, inshallah. But we currently face this thing. We have a higher number of elderly people that we need to serve. So what we can provide for them, what we can provide, even in the US, the elderly people are, the number of elderly people are jumped very high in the last few years. It's doubled. And even in Europe, the number been tripled the last 10 years. Okay, in comparison between the two gender, we find that the number of the elderly people, the level is jumped to 87 years old for the ladies, and the opposite is 83 for the men. So we have now two types of people who are targeting. We spoke about the elderly people. On the other hand, we speak about the disabled people, the people with disabilities. So in Saudi Arabia, we have the APD, the Authority of the Care of People with Disabilities in Saudi Arabia. They identified these portions of people are the individuals with partial or total impairment in abilities. So it may include physical, sensory, or intellectual, behavioral, or learning disabilities, and limit on their performance and participation in the society. They, of course, require special service and accommodate based on their needs in different activities. And it's part of the quality of life to provide such people, such services, to provide them what they need, and to make them able to use facilities in different occasions. So the problem we tackled in this presentation, this research, that we need to have a scalable real-time monitoring for elderly people based on vital signs and even disabled people. And we care about the data reliability and motion detection for different readings for those people. And how are they using or they are conferred or not in the usage of different services. We measure their stress and what is the clinical procedure that need to be worked with these people during their activities when you speak about Hajj and Umrah, or even different aspects or different type of activities. We developed an AI-driven continuous monitoring system, and I've been using it in different research. We use it in research to measure the stress as a stress detection system. So we don't wait for the problem to happen. We prevent it before it happens. So we read these vital signs, we analyze it, and then we expect the problem to avoid it, not to wait it to happen in its worst case. So we integrated wearable sensors and applied it on the edge cloud, and we use an explainable AI tool. These all are used to evaluate the prototype of visibility and performance of those people, elderly people, and the disabled people in different scenarios. So in the literature, we made some screening about what is available in the market, what is not available. So we found some wearable devices. It has different accuracy, has different ability to read some of the vital signs. And the other side, also the AI systems are still not mature enough to provide huge service that can be provided through AI. So there is a lack of different services provided in this technology. We still need to learn and make our AI systems more advanced to make our services provided to elderly people much better and much accurate. We have a few works integrated the edge cloud and explainable AI for elderly care, and it's a huge market now in the healthcare systems. The system we used in this research effort, we have identified 3 layers. We have wearable devices like Apple Watch, for example, or Huawei Watch, are all these sensors. Maybe you can recall some accidents happened mentioned in the media. Someone, an elderly man in US, fall down on the ground, and a notification being sent to his daughter. Not in the same house, she was in work. She notified through the Apple Watch that her father been fall down in the house, and she received an alarm message to help him. This is one of the samples. We hear also one of the accidents happened, I think in the US also, a car accident done, the notification be received by the Apple Watch for their family that someone of their family been injured in an accident. So there is multiple use cases, different implementations of technology that we need to employ it for elderly people. And we applied it in this research by using the wearable sensing devices like Apple Watch and other. We have the hair traits, we have a oxygen level, we have a skin temperature, the activity report that can be generated out of this Apple Watch, for example. We have an edge cloud processing that taking this data and put it in the edge in the cloud and filtering it and detect abnormal activities and secure transfer of data that protect the privacy of the users. And then in this agent or engine or AI engine, we have analytical and explainability using long short-term modules and shape modules. It's all used to understand how these data are interpreted and used. This is the architecture that we used. We have in the left side, we have the sensing layer. So reading data and push it to the cloud. The cloud will, and the edge cloud processing that, collecting data and protect it, of course, and analyze it. And we push it to the cloud platform that has the AI to analyze it and train based on the trained models to understand exactly what's happening in based on the vital signs, and push it to the storage or notification system to the users and the caregivers at the back sides. So we have a full stack architecture that can provide the service that we are looking for. Here is a summary of the system architecture that we use in our system. In each layer, we have a collection of data and processes. The most interesting is how to use this data and analyze it. This is the core idea. I have a lot of data and I had a lot of sensing data. What I can do, we train the AI system in this block that we can understand whenever there is an increase in the blood pressure, for example, or the heart rate. That means it's a sign of failure in this person, and we understand this signs and early preventing this system by go and try to solve and protect or prevent this the worst case in such a system. So the AI model used the LSTM, one of the machine learning processes that for psychological time series data. It has, as I said, inputs. We have readings, we get it. So this inputs will analyzed and find the anomaly scores and risk prediction. And we then understand it from and interpret it from a clinical and caregivers perspective, and do this like a last step of our system. The prototype implementation, we have used devices. We have an edge like smartphone gateway. So we have our we can say the wearable device, and there is a device that collects this data and push it to the cloud. And after the cloud, we have a system that has a dashboard to show the caregivers or the results of this system. We have results presented in different levels. For example, we used our system in to participate for 2 elderly people participating in this research. We have a duration of this research about 3 days. We collected some data. We used some walking, stairs, climbing, and very light exercises. So we use this data to build our database that we can understand and learn from this database, improve our AI engine and machine learning system. So we have different key results. The most interesting thing is the data loss that in our system was very very limited. Alhamdulillah, it was high accuracy also in detecting the heart rate, reading the oxygen level in the blood, also readings. And then we have a good shape model that gave us a clear explanation of anomalies and understandable readings. And our implemented system, we have of course strengths and we have limitations. The main strength was we have a reliable real-time monitoring system. And this was the most shining thing in our research. We have also a transparent AI outputs. So whenever we have vital systems, we have good readings, and we can analyze it and use it to provide a machine learning system. The limitation was we have, fortunately, we have, of course, a small sample size. 2 persons is not enough. Of course, we need to enrich this data set, with a huge number of volunteers or users. And we need to also to use different environment. We used control and closed environment in houses and the best shape. We didn't use scenarios like people who are going out or going walking around. So this was one of the main limitations of our research. So in future work, we are going to work with larger scale. So with real-time deployment and real-time scenarios, and we are aiming to use advanced AI that have a semi-supervised and different models of machine learning, and improve the caregiver friendly explanations of these data, and use an integration with the EHR, heart rates, and the telemedicine services. In conclusion, AI and machine learning are a powerful system. So any AI-powered systems is giving you a great opportunity to expand your services, especially for elderly people and disabled people monitoring services. The prototype showed feasibility, interoperability, also the foundation for scalable elderly healthcare solutions. So we, of course, we done it on 2 person. We can expand it to 100, 200, 1,000 person. So whenever you add data, you enrich your data set and data system, and the solution will be much better than unexpected. This was my talk. These are main references being used. I hope I added some information or important details about how to employ wearable devices and AI solutions, and providing elderly people such a quality services, and also disabled people a great experience using technology that we have. Thank you for your attendance and your hearing, and if you have any questions, I'm here to serve. Thank you very much.
Thank you, Dr. Mazen. There is any question for Dr. Mazen? What is topic? Okay. Our next speaker is Dr. Abdurrahman Bashauri, Supervisor of the Safety, Emergency and Disaster Research Unit and Crowd Management Consultant for Hajj companies, and member of the custodian of the 2 Holy Mosque Institute for Hajj and Umrah Research at Al-Qura University at Mecca. He will speaking on the role of crowd medicine in managing health safety in the campus of Mina, Mecca al-Mukarram.
Assalamu alaikum warahmatullahi wabarakatuh. Ladies and gentlemen, I am warmly welcome you all to this distinction conference, and it's my pleasure and honor to present a talk entitled The Role of Crowd Medicine in Managing Health Safety in the Campus of Mina. First of all, I'm going to give you an overview and then tangible value of this project and what's the difference between a general 10 and a 10 in Hajj campus, and also some crowd safety requirements which we need to consider inside the tents, and what's the difference between undeveloped and developed tents in terms of Hajj campus, and also some result which we come up from the questionnaire tool and observation. And at the end, we are going to give you some recommendations. Spending the night in Mina is one of obligatory rites of Hajj. However, some housing services in Mina suffer from shortcomings in meeting crowd health requirements. This is an urgent need to enhance the quality of campus in Mina. The tangible value of this project, ensuring safe campus that provide health environment for pilgrims and accommodate their needs and preferences. And this is what we are going to consider on the tents in the Mina. So, what is the tent in general? Tents are portable shelters with a cover and a shelter and structure. Tents and tent is not just a roof, it's habitable cover living space. It must have blankets, mattresses, lighting, ventilation, and access to service such as water and sanitation. The main purpose of a tent is to provide protection from undesirable weather conditions, to segregate people so then disease is not widespread, to give a sense of privacy and to prevent harm due to overcrowding. So the 10 in the Hajj campus are temporary facilities in the form of equipped tents established in the holy sites of Mecca, especially in Mina and Muzdalifah. They are designated to accommodate pilgrims during the Hajj rituals, providing them with the places for rest and sleep, along with the essential services such as air conditioning, electricity, water, meals, and sanitation facilities, ensuring their health, comfort, safety, and organize the movement within the holy sites. So what are the crowd safety requirements in the tents? In terms of crowd management and organization, clearly define the maximum capacity of each tent, plan the distribution of pilgrims to avoid overcrowding, deploy trained field teams to manage crowd flow and evacuation in emergency cases. In terms of support and medical services, ensure tents are closed to first aid and mobile medical points, equip rapid response first aid teams, provide effective communication channels between organizers, security, and medical teams. In terms of emergency exits and evacuation routes, provide a sufficient number of exits according to the tent's capacity, mark exits with clear illumination and emulated signs, keep all pathways unobstructed at all times. In terms of structural safety of tents, use a fire-resistant and civil defense-approved materials, secure installation of tents to withstand wind and load, clearly pathways between tents to allow smooth crowd movement. In terms of fire protection system, install smoke detectors and fire alarms inside the tents, provide appropriate fire extinguishers and train staff to use them, prohibit hazardous heat sources such as gas stoves and charcoals. In terms of electrical installation, use installed insulated certified electrical wiring, distribute electrical load safety and separately, provide an emergency circuit breaker. And there are some specifications from Hajj and Umrah Ministry in terms of increasing the health condition in the tents like shaving service and cleaning specifications, and each capacity of Hajj in undeveloped tents. This is an example of undeveloped tents and how they distribute the sofa beds inside and without any space between the sofa beds. In terms of developed campus, they increase the specification and they increase the capacity of Hajj from 1.6 to 2.5. And it's look like that. They increase some bath movement and make partitions between the beds to decrease the separate of the diseases and infections. And we've done valid evaluation of sanitary design factors by questionnaire and observation. And we go through the space, types, and size, and movement, privacy, noise, cleanliness, term formal, and natural lighting and natural or artificial lighting. There are some results from the questionnaire and observation. And as we can see in undeveloped tents, no space between sofa bed, but it's improved in developed tents and make it more space. And in terms of the type and size, they use in the undeveloped tents and sofa beds, but they use it in the developed tents bed, but still we have issuing like such as we can see extending the legs because of the small size of the sofa and bed. In terms of the movement, also there is a difficulties, especially in evacuation situation. In terms of the privacy, we can see it has been improved in developed tents. In terms of the noise, okay, even no space for eating inside the tent in undeveloped, but it's developed in developed tents. In terms of the cleanliness, we can see it's okay, not that bad. In terms of the thermal comfort, they use split air condition. In terms of the natural lights, also there was insufficient material for isolated in undeveloped tents, but in developed tent was no natural lights existing in the developed tent, especially in the outage of power. So we developed a prototype of the tent by increasing the number of beds from 20 to 43 by installing bunk beds. Also, we installed 6 beds that are 2 meters in length for tall people. Also, we install a specific bed for the use by people with the disability. Also, we develop and provide bed tables that fold down along the side of the bed to make the movement path clear. Also, we provide storage lockers, space of hang clothes, and also window to get the light inside, especially natural lights. And also we thought about it's a prototype for multi-story of the tent to increase the number of the pilgrims and make a roof above to use it for other services. And this is the distribution for the sofa beds inside. So we can use the more area for other activities like prayers. In conclusion, crowd medicine plays a crucial role in ensuring health and safety in the campus of Mina. Effectively plan preventive measures and rapid response help minimize health risk and protect pilgrims. working together to raise awareness of ensure a safe and healthy environment, allow every pilgrim to perform their rituals with peace of mind. Thank you so much.
Thank you, Dr. Abdurrahman. If there is any question for Dr. Abdurrahman about his topic? Okay.
What are the different types of human gatherings? Do you think that in Makkah, if the Hajj pilgrims are in Mina, and after Hajj, after 12, they are residing in the Makkah city, there is any difference between these two crowds? You are getting my point?
No, could you please repeat it?
Do you find the difference between the crowd in the Mina and after finishing of the Hajj, they are scattered in Makkah city? So what is difference between these two gathering?
Yeah, they all work together and they're all using the same rules and specification for managing the crowd in terms of in holy sites and also in Haram and inside the city of Makkah.
No, it means if they are in Makkah before the 8th of Zul-Hijjah,
Yeah.
or after 13 of Zul-Hijjah, they are scattered all over the Makkah. But in Mina, they are gathered in a very specified space and hold the crowd of the Hajj, like 14 lakh or 16 lakh, this time probably 16 lakh. So 16 lakhs people are staying in Makkah in a closed specified space. And after Hajj, they are in Makkah city. They are in different hotel in entire Makkah. So crowd is not the same. Their necessities are not same. And most problem in Mina is toilet. The large pupils and a small number of toilets, they are facing a lot of problems. The most sanitation is needed in toilet. Most crowded pupils are hundreds in the line for waiting for their natural need.
Actually, there is a specific, party and groups in Al-Hayya Al-Malakiyya. They are organized all the crowds with some techniques and some programs, and they're distributing in safe.
Suppose the FIFA is going to held in 2034. And every year, pilgrims are coming 15 lakh, 16 lakh. Before this one, they were 29 lakh, 28 lakh. So the crowd in the FIFA and crowd in the pilgrim are the same.
I think it would be the same, but with different languages and with different backgrounds. And this, we are going to consider that. But in terms of the techniques, I think it will be the same.
There is difference because when they will be in 2034, they will be distributed in all the big town of the Saudi Arabia. Some will be in India, some in Jeddah, some in Medina, some in Abha, Jizan, like where they are a playground. And in Hajj, they are crowded in Makkah and Medina. And another difference, the players and loving play, they are usually young. And in pilgrimage, right from pediatric to geriatric age. In this crowd, in FIFA, young pupils are having less chronic diseases. And in pilgrims, mostly they are old age and above the middle age. So they are having a lot of chronic problem. diabetes, hypertension, kidney failure, ischemic heart disease, and so on. So the medical demand is not the same for this crowd and that crowd. Entirely different.
Thank you.
Thank you. We get your point that there is a difference in demographic between the two populations. That means there is a difference of need for these two populations. Yes, this is correct. Any other question? Okay. Our next topic, inshallah, will be smart health and safety monitoring for Hajj and Umrah worker using AI, also by Dr. Mazen.
طيب بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على سيدنا رسول الله. As it's a part of our research also to use advanced technologies like AI and IoT, we focused in this paper or this research and the workers of in Hajj and Umrah. So we have a lot of research and a lot of efforts done for Hajjis and pilgrims. But in other sides, the workers in Hajj and Umrah still not have the same type of concern about how to improve their prediction and prevention of healthcare, especially in a stressed atmosphere like in Hajj and Umrah. In this paper, we focus on the workers. They have, of course, the right to be concerned about. And during our experience in Hajj and Umrah, we faced a lot of issues related to people who are working in Hajj. We have a lot of conditions that they are facing, hot weather, stress work, long time working, and complicated communication and during Hajj. These are all things are for making some impact on those type of people who are working and serving Hajj and Umrah. We have a large scale of workforce. We have about 350,000 person who are working in to serve in Hajj and Umrah. So it's a huge number of people who are serving from different sectors, from military sectors, from health sectors, from service provider sectors. For all these are people who are working and serving in this in different conditions, in different atmosphere. So we have a harsh condition, as I said, heat, crowding, long shifts are very difficult conditions. Health and safety changes like fatigue, heat stress, accidents are all we face during Hajj as a worker. And we need to employ AI and IoT technologies to have a real-time scalable monitoring for those people as well. The importance of caring about workers, why it's important. Imagine that we have about 1,300,000 Hajj in a zone. Each worker is serving about from 4 to 5 person at least during Hajj. And this person is working for long shifts. The average shifts we are working during Hajj is 12 hours. I know some people working about 18 hours. So he just go to sleep and come back to work. So imagine this very stressed condition. And this is the nature of Hajj, by the way. It's a ayamun ma'dudat, very little days. We put more energy, more focus on this very narrow time, but we really need to focus on some health aspects that we, as a worker in Hajj Umrah, we are facing. So how to make those workers safe, healthy, efficient workers. So caring about the health of the workers is very important because it's reflected on the quality services provided to those guests in Hajj. So preventing accidents as well. So we have few accidents we faced. Imagine that a driver who is working for long shifts and he is driving a bus with 50 person with him in the same bus, and he's sleepless or he haven't slept. So this is a dangerous situation. We can't allow such a situation happen for such a people who are driving for too long journeys. One of the main concerns of this research to prevent such things to happen. So we're trying to prevent accidents. We're trying to prevent also delays happen from overworking time and health crises that can happen because of those long shifts and conditions happen. Aligned with also the Islamic values and the targets of the Vision 2030 that pilgrims experience should face a good services and provide them good service through the workers. Okay, so workers are the front line who are facing the guests and the pilgrims. So we care about this front line, especially in people in the field who are facing the services provided. So this is an example of fatigue. Not only the military people, not only the people in the field, also the doctors and the healthcare providers. They face a lot of pressure, a lot of long term, based on the nature of their work. So the problem statement is we have a traditional monitoring in manual and fragmented and reactivated services. So issues detected too late. So we face some people who are very stressed in Hajj. They suddenly fall down because he didn't realize that he need to have rest, or he didn't realize that his body is sending some messages about his health and he is not caring about his personal health. So we need to understand those people are trying to give their best. Even they are not all people, they are young people who are facing stress and get stuck with overworking. And of course, the high risks that can face as heat strokes and dehydration, also cardiological issues and injuries. So need to for a predictive and also a real-time solution. So this is one of the main concerns. And we made a number of research, and also other parties made a lot of research about this, how to use the technologies. We employed in some of researches, of course, for pilgrims, using, as I mentioned the first talk, smart watches. This is the most valuable devices that we can use and provide to our pilgrims or even the workers. We made some research, as I said, for pilgrims, but we still not employ research for workers, unfortunately. That's why, because we care about our guests, but sometimes we don't care about ourselves as workers in Hajj and Umrah. And the aim of this presentation is to care about ourselves and how to give the better of us, what we can give better services through this technology. Yes, we employed a model. We are just focusing on how to build an AI and IoT ecosystem for monitoring. That will provide, of course, real-time monitoring, predictive analysis, and smart interventions, and improve also the efficiency and the well-being of our workers in during Hajj and Umrah and the special events. The architecture we used, we have the same architecture for we used in pilgrims, wearable sensors, and the data layer for vital and location detection and activity detection. Provided some AI algorithms, and that can also have anomaly detection and prediction. Also, we integrated the cloud, and the response was how to make notification, dispatch, and provide the user a full report. So about his health, that can be also generated not for himself, but the team leader and the responsible parties of those people who are working on the field. The technology also with same usage, we have machine learning assist detection, and environmental sensors also are employed, like a temperature, humidity, COT level. You know, in Mecca, we have about 75 tunnels, big tunnels in Mecca. Imagine that people who are working inside these tunnels, the COT level is very high in these tunnels. We have to provide some indications that people who are working inside these tunnels and sometimes it's not safe for them because of it's full of buses and full of vehicles. That's why there is no such a device to read this level unless the tunnel sensors, the sensors in the tunnels that can reflect it in the dashboard and inform the team leader or the leader of the shift there. This is implementation of our system. You can see the user have different sensors. Okay, these sensors are collecting data and pass it to the cloud. We have the network system there. The cloud will then we have different type of clouds. We have 5G clouds, 4G, LTE, and this cloud or this network system pass it to the monitoring platform. Of course, we have AI and deep learning engines that analyze this data and provide the early detection and early prevention actions to the users. It's already there in somehow, but the different applications. We try to employ it, and alhamdulillah, we have some employment by Sadaya, for example, during the last 5 years for research purposes, and we employ a number of our researches being published in Q1 journals for Hajj and pilgrims. And we focusing, of course, as I said in the first speech, about elderly people and disabled people, and also the workers in the other side. Okay. I'm gonna speak about what we provided for pilgrims. We have the same case we employed in the pilgrims. We went through the last 3 Hajj seasons. We collected data about pilgrims. We done some research about how to expecting problems before it happens, and we succeed by measuring the stress of people in Hajj. The stress level was in different locations in Mecca, in Arafat, in Muzdalifah, in Mina. We identified the stress location that pedestrians, pilgrims are facing. Also, we identify some issues for people who are inside the buses. You know, you think you are in a bus, you don't have a stress. No, we found there's a high stress level for people who are waiting in buses for long journeys. And this was an indication that not everyone in the bus is not stressed. But and not everyone he's walking he's stressed. No, the thing is we have different aspects. We have location-based, we have stage-based conditions, we have time-based location. We identify these and trained our models to provide an AI model that detect based on the stage, location, age, gender as well, and even how long waiting time and the stress level for each pilgrims that we can help them through the smart wearable devices. We have a lot of results. I will save some time to not go through it because it's very detailed and technical. And the use cases of Hajj and Umrah workers is focusing on monitoring staff in high temperature zones. And this is one of the main concerns in the middle of the day, from 11 to 2 p.m. At the middle of the day. It's a very dangerous time that we are providing services for those people. So caring about them, about their body temperature, how to prevent them from to save their life even as a workers, and also tracking the logistics and transport workers. And this is we have about in Hajj and Umrah we have about 37,000 buses. You imagine that, and we have about 50,000 workers only in the transportation sector. All these are working continuously. No monitoring for their health. This is an issue. A driver is responsible about 50% live. So we try to prevent and provide better quality of service for those important people who are giving services. We also can send alerts to the supervisors to prevent incidents using such early warning systems. The benefits and the impact, of course, we're gonna have healthy and safely working atmosphere. Imagine that Hajj Umrah is gonna be the best working atmosphere. How we can do that? We can do that through a good monitoring system. We need to care about our health and Hajj and Umrah, of course. And also this will improve the efficiency of services. If I slept well, if I'm healthy, I can serve Hajjis better, of course. So reduce the downtime and also better workforce usage. Also data insights, so we can have a good planning for future services. This is all can provide for as a part of the smart cities and transformation, intelligent transformations systems based on the Vision 2030 as explained. Challenges and considerations, of course, we have data privacy and security of data. When I collect data from you, I need to make sure it's safe, it's protected, and not go on your privacy data. So this is what we care about it in the cloud. Workers' acceptance of wearable devices. There is a challenge of how to make someone wear a device and he understands this device will protect him. Unless he understands this is a must for you to work in Hajj and Umrah, because we care about your health more than we care about how you're gonna provide or do your job. Integration with current platforms is also a thing that we care about. We have Nusuk platform for people who make Hajj, and also people who are serving those Hajjis. We care about how to combine this system with a Nusuk platform as well. Infrastructure and device durability, also one of the challenges. This is a use case that I need really to demonstrate with you. Last year or last 2 years before, I've been invited to deliver a speech in in the Smart Hajj conference by Ministry of Interior, and I spoke and I made a workshop about the importance of monitoring the workers, especially military people, health during Hajj. Alhamdulillah, last year there is an initiative by Ministry of Interior. They provided initiated a wearable device that number of the military people used during Hajj from different sectors in military, and they used it to collect data and care about the healthcare of those people in Hajj. The purpose was to care about people of security and the health of their safety, because they are standing in the field maybe for 12 hours, up to 12 to 16 hours sometimes during the peak time. So the vital signs, the vital data are very important to read and understand for emergency, to provide emergency alerts when needed. Blood oxygen, heart rate, blood pressure, physical activities, body temperature, other are all collected through this initiative by the military devices that used by them in during Hajj. So the alerts will be collected and detecting the early warning alerts and sent to the command center. And the command center in the Ministry of Interior are monitoring their health, their forces' health, of course, for and the emergency teams, the healthcare providers for military also care about this data. The benefits is to enhance and the prevention system and ensures the rapid response. Of course, if someone of those individuals are suffering from something, it's early detection and improves the overall health and safety and security, and also personal in the field health reporting system. In conclusion, we can say that the extreme heat, the crowd density, the long shifts are very challenging issues in Hajj and Umrah, especially in Hajj. The traditional monitoring manual is fragmented and reactive, not proactive, is reactive. Whenever we have an accident, we then activate it by an action. We need to prevent, not to be firefighters when a fire happens. No, we need to prevent the fire before it happens. So AI and IT solutions are predictive and proactive and real-time monitoring system. Wearable devices are capturing vitals and different AI for early signs and fatigues and stress dehydration also. All are part of this efforts. So workers are the backbone of Hajj Umrah. No issue about that, or no doubt that if we have a good workers, healthy, protected, safe, we have a good Hajj Umrah atmosphere. Even in big events, if you have a good crowded workers in good health and good shape, you can have a better services. Smart monitoring saves lives and prevent incidents. Also boost workforce's efficiency and reduce the downtime of Hajj. You know, we are as Hajj workers, after Hajj, we have 2 to 3 weeks at least to recover from Hajj season. 2 to 3 weeks. Imagine that, just to recover from the downtime of Hajj and Umrah. Why? Because unfortunately, we followed a bad habit, about care about ourselves and care about our crew or people who are working with us. We need to prevent that by using technology and also employ a stressless working atmosphere. Supports Vision 2030 by providing pilgrims experience quality of services. Also, as we speak about AI-driven predictive digital twins and for the workforce and health and safety. Also integration with national health records and provide these services not for people who are working in Saudi Arabia, also the people who are serving Hajj from outside Saudi Arabia, they come with the Hajjis. We need to care about their health and services provided. And when we care about scalable and deployment across sites and peak seasons. That's all from my side. I hope I added some informative ideas about how to employ AI and advanced technologies and serving the crowd in Hajj and Umrah and big events. If there is any questions, I'm happy to hear and participate. Thank you very much.
Thank you, Dr. Maza, for your great contribution. Thank you. Is there any question?
Congratulations. I must confess that I'm very impressed with your use of the AI and the technology for the management of the personnel, and that's very caring. Only thing is probably the same system can be done pre-deployment, which means we can actually assess the psychological profile, the emotional profile of the personnel before they do, and where the intervention can be done prior rather than just detecting during. Yeah, I'm just saying that to be more proactive and to be more preemptive. And I actually like to work together, do some research, because I'm more into the impact of digital technology to the psychological profile of the young, of the generation millennium, alpha and beta.
Yes.
Thank you. Congratulations.
Thank you very much.
Thank you. Thank you.
Thank you, Professor. Actually, one of the best models that we have in Hajj and Hajji is the Malaysian model. It is, yes, to be honest, and we are in Hajj experts, we also always cited the Malaysian model as the best model of Hajjis who are coming to Saudi Arabia. Because they care about three things: about their quality of service provided for their Hajjis. They have good and strong training and preparation system. And also they have an RDI, a research and development party that care about developing the service for the Haji from their country. So they care about Haji from Malaysia to Malaysia. And I will have some speak about you because I'll be in Malaysia next week. Inshallah, for such a purpose, we can speak about it. But yes, stress is very important. We began about 5 years ago how to measure stress before the worst thing happened. I think in people in medicine, in medical field, they care about this. We prevent, not to a cure. Okay, so this is the provided by technology, inshallah. And thank you for your question. Any other question, please?
Thank you. It is like a suggestion that every country, they are having their Hajj committee. Yes. And they are analyzing the data, problems in health, communication, and all that. When you share the data from other country, their difficulty, their problem, then it will be more clear for planning the next year Hajj for health and others. So my suggestion will be to communicate with other country, find out their data for problem, needs, and availability. Yes. So that you will be in a better position to plan the giving facility to the pilgrims, like India, Bangladesh, Pakistan, Malaysia. These peoples are, means most of the population of the Muslim. And Hajj pilgrims are coming more from this country. So yes. If proper contact and collection of data, their problem and their need, you get it, then you will be better in a position to plan, to give more facility and better facility.
I'm speaking about, thank you for the question. As a researcher, I'm quite agree that we need to understand the health profile for each Haji before he come. And inshallah, this is one of the target thing by the legal authorities here in Saudi Arabia, like Ministry of Hajj and Ministry of Health. They care about to provide these services, not in Saudi Arabia. We can help the pilgrim from his country to provide such a great services, because AI is an automated tool and available for everyone. And each pilgrim will have a special file in Nusuk system, inshallah, soon or later. I hear this in the last Expo, Hajj Expo, that Ministry of Hajj is caring to provide and extend the services for Hajjis in better health and service provided for them.
And
Thank you very much.
every country are sending their medical team to provide
Yes, yes.
medical facility for their own people. So they are also having medical data. If you contact with medical personals of every country, they are having complete data for
Yes.
the health structure and what facility. So it also be very beneficial for the better services from the health side.
Of course.
Yeah.
Thank you very much.
Thank you.
very
It's
much.
nice input from you. I think there is already exchange of information between the country that we going from the pilgrims to Saudi Arabia. I think there is a communication between and exchange of medical data from the pilgrims commissions. Okay, thank you. Thank you, Dr. Mazin. Our next speaker is dear colleague, our paramedic Mustafa Gouta from the Saudi Red Crescent Authority. He will be talking about ambulance allocation and response and how the Saudi Red Crescent in Al Madinah Al Munawwara meets the 2030 vision goal. The floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. First thing, I would like to thank the conference committee for giving us this opportunity to show the hard work we are doing in the Saudi Red Crescent Authority. So in my lecture today, so today we are going to know about the ambulance allocation and response here in Medina, and how we improve the response time to achieve the Vision 2030 goals. So we did several things to improve the response time, but today I'm just going to talk about one of them. So the several things, one of it that we used we improved our dispatch system. We used the Brookie global system to categorize the data into the severity. And also we use the sector system. And this is what I'm going to talk about today. So first of all, I'm going to talk about ambulance allocation and sectors. And then what happened before applying sectors and what's happening now after we applied them. And then the national indicators and how we are improving them. Then I'm going to talk about the ambulance fleets here in Medina, what's the type of vehicles we are using. And last thing, I'm going to talk about a percentage of ROSC cases and number of ROSC cases. So we divided the city into 3 operational sectors. So each sector has its own chief paramedic, that's like the manager for the sector. Each chief paramedic has 4 to 5 assistants. So in their shift, they were called chief paramedic in duty in his shift, each assistance. And each sector will complain at least from 5 response units. During peaks or gathering events, the number of units might increase, doubled, or sometimes tripled. So type of units we have A-list and B-list unit, and RRU. RRU is rapid response unit. So the A-list unit contain from paramedic and paramedic, or paramedic and EMTs. The B-list unit will contain EMT and EMT, or EMT and driver. The rapid response unit, it depends. Sometimes it's only one healthcare practitioner, and sometimes there are 2, depends on the type of the vehicle and the equipment they have. Last thing we are going to talk, also we have the involvement of the private hospital to increase the allocating points of the ambulance. We had this initiative, we started at Uhud sector, one of our sectors. We have involvement of the private hospital to respond to the cases with us. So the hospital will provide ambulance station. They will provide 1 ambulance with its equipment. They will also provide driver, and they will provide 1 healthcare practitioner, all of that with 0 cost. And one of the Saudi Red Crescent staff will go to the hospital, and he will work with them to respond to the cases. And according to the agreement, it depends with the hospitals. Sometimes the private hospital will also provide another healthcare practitioner. So that one will go and he will work at the ambulance station itself, not in the hospital. We can see here the map of the sectors. We have in the purple color Uhud sector, and we have in the yellow color As-Salam sector. We have here in the green color in the small area, this is Al-Haram sector. Yesterday, Prof. Al-Ghamdi, he mentioned about dividing areas into zone, and one of the recommendation in his lecture was to make zones to manage better. So this is actually what we did. We divide the city into 3 operational sectors. So if you can see, there is a small blue color. This is one of the private hospital. They are covering this sector. Also the red color, this is, but they did not work yet, but we are planning for this. There is a hospital, they have 2 branches. So they are going to give us two allocating point to cover more area. As you can see, the green color Al-Haram sector is very small comparing to the other sectors. Actually, the division of the sectors, it's not according to the geographical area. It depends on also in how many people are there. So as you know, in Al-Haram sector or in the central area, we have more people and more crowd than other areas. And we are going to see in this lecture prove about with the numbers how in Al-Haram sector they have more patients than the other sectors, even when they are large in space than Al-Haram sector. So here by number we will talk about we took 1 month, the same month before applying sector, and after applying the sectors, we compare number of cases with the response time. So first we have Uhud sector. As you can see, the number of cases before applying the sectors in the same area was about 1,700 cases. So after we applied the sector, we noticed that the number of cases, if you can see in all sectors, increased about 500 cases per month. So if we did not did anything, so the response time will increase, will not decrease. As you see, before applying sectors, when the number was about 1,700, the response time was about 26 minutes. But after we apply sectors and number of cases increased, we actually decreased the response time to 12 minutes, from 26 minutes to 12 minutes. This is the same month before and after applying sectors. If you see at As-Salam sector, number of cases at that month was about 1,800. After applying sector, it's also increased to about 2,600, and the response time decreased. It was 25 minutes, and it decreased to 10 minutes, and that is a huge decrease, and it's almost 2.5 times the response time. At the end, we can see Al-Haram sector. As I just mentioned, it's a small area, but if you can notice, they have more cases than the previous sectors. And before applying the sectors, they were having about 2,400 cases, and after it reached to about 3,000 cases. So the response time decreased from almost half an hour to only 11 minutes. So we asked our employees what is the difference between before and after applying the sectors. They noticed that the response time is improved, as we just also see in the numbers in the schedule. There were less absence rate because there is less rate of burnout. They are not feeling like they are burning out from the effort. They feel that they belong to this sector because if you remember, I mentioned in the beginning, each sector has its own chief paramedic, and each chief paramedic has 4 to 5 assistants. So before applying sectors, it was called, they were calling field captain. So the field captain was responsible for about 15 units, but after applying sectors, each chief paramedic in duty is responsible for only about five response units. So he is one of them. He is one of their colleagues. They know him very well, and they feel belong to them, and they will be cooperative. And also they feel acceptance. They accept all cases. Before applying sectors, sometimes they will go too far, and they will maybe have bad feelings. But now all the cases are nearby them, and they will accept all the cases. They notice, they feel also that the number of cases before applying sectors were more. And we just seen here by number that after applying sector, the number of cases increased, not decreased. And they feel that because, as we said, all the cases are nearby them. They don't have to go so far. And after applying sectors, before applying sectors, if there is any case, the nearest response unit will go, even if it's too far. After applying the sectors, even if one of the sectors, they have waiting calls, the other sector will not respond unless if there is real emergent cases, such as we're calling it echo cases, which, for example, include the CPR cases, choking, and also if there is a car accident, they will go, or a patient is gasping, for example, they will go even if it's from another sector. So the national indicators, we are measuring here the response time. You can see here real data from the beginning of the year, from January until August this year. You can see the response time. It was about 10 minutes, and now we reach about 8 minutes, and we are aiming to decrease this number. Also, yesterday, Prof. Saeed Al-Ghamdi, he mentioned the response time will be 8 minutes or less, the goal. So we are trying to meet this goal. You just see in the previous schedule that the response time was almost half an hour or 26 minutes, and we decreased it to 10 minutes. And as you can see here, also in the emergency call, we are aiming to go to the emergency call in less than 8 minutes. We want to reach to 80% of the calls. As you can see here, also we are improving also in this percentage. I just wanted to see in March, all the numbers are better. You see the response time were about 5 minutes, and the percentage of emergency calls in less than 8 minutes, it's about 71%. Because in March, it was Al-Umrah season, it was Ramadan. So we have large number of response units. And when we have large number of response units, we can allocate them in the hot zones that we are, if they have like large number of cases, we can allocate them there and they can easily respond to the cases. Also, we have the accident, special response time for the accident. We want to improve it. The echo response time also, as I mentioned, the echo include the CPR cases, choking, and if the patient is gasping, and real life-threatening cases. Our aim also to be less than 8 minutes for the echo cases. We started the year by 10 minutes, and now we are nearby the 8 minutes, and we are trying to improve the time on that. So ambulance fleet here in Medina, this is the only things that the only vehicles we are using here. The Saudi Red Crescent Authority, they have more than this, but this is the only things we are using here in Medina. So for the helicopter, the provider, they will be advanced paramedic, they will be certified critical care paramedic and flight paramedic. They will respond to too far places, and or if the area the ambulance cannot reach, so the helicopter will reach there. We have the normal ambulance van. There will be B-list or A-list unit according to the staff. We have the 4x4 vehicles, and some of them B-list, A-list, or some of them are just rapid response unit for only rapid response and treatment on the scene. Some of them, they can transfer the patient, and some of them not. It depends on the equipment and the staff on the vehicle. We have the motorcycles and bicycle and the scooters. They are one provider. They will have, they are only for rapid response and treatment on scene. Sometimes the cases, they don't need to be transported to the hospital. They just need to receive treatment at the scene. We have the golf cart. The golf cart also divided into two. We have B-list and A-list. So the A-list unit, they will have devices like life bag for defibrillation and basic cardioversion for doing ECG. And they will have medication, including narcotics also. And the other team for the golf cart will be the PLS. And some golf cart in Al-Haram, we call it hybrid. There will be one staff from the Red Crescent and the other one is volunteer. We have also Tuweg bus and Uhud bus. There are buses for containing large number of patients at the same time. And we have Sanad for logistical support. Basically, they have a large number of equipment. If we have a mass gathering, if we have a mass casualty, so they will be there. If the equipment finished from the ambulance, such as oxygen cylinder or any equipment, they can take it from Sanad truck. We can see here we have, this is the helicopter, this is the regular ambulance van. We can see here we have the 4x4 vehicle. By the way, this black color, it's called Ubayya. It's named after the horse of King Abdulaziz. So in this vehicle, we are not transferring patient. They just have the equipment and the devices. They can rapidly respond to the cases and giving treatment on the scene. In the other picture, we can see the motorcycle. And behind it, we can see the patrol. They are 4x4. This vehicle, they can transfer the patient. They have bed inside this car, and they have large oxygen cylinder. So it's like the ambulance van, but for specific areas. As you see here, we have also the scooters and the bicycle. For sure, safety is first. They're wearing their safety, and they have a specialized bag for each one of them to respond to the case and to give treatment on the scene before the ambulance car arrive to, if the patient need for transportation. This is the Sanad truck. This is the Sanad for logistical support. They have all the equipment, extra equipment if needed. This is Tuweg bus. As you can see here, there is 4 beds and there is the seats. This picture from the half of the bus. Behind that also there is another 4 beds with the seats, so they can contain large number of patients. We use this most of the time, mostly when we have a bus accident. You know, the bus accident, they will have a huge number of patients, especially if two buses are crashed to each other. So we will have large number of patients. About the ROSC, we can see here in 2024, before applying sectors, in the first half of the year, the number of ROSC, the percentage of ROSC cases was about 14%. After that, after we applied the sectors in 2025, for the half of the year also, the ROSC cases increased to about 22%. And we are aiming also to get more percentages than that. Last thing, I want to show you this picture. In 2024, we had 216 cases that they get ROSC, and this is the name of my colleagues that they achieved this achievement, and we are aiming also for more. Thank you for listening. I hope you enjoyed the lecture and you add some information to you. Thank you.
Thank you very much, Mustafa. Is there any question?
Assalamu alaikum. Thank you for the valuable information. One of the slides you talk about national indicators. My question is, what is the benchmark you are comparing with?
We want to reach for example, for the response time, we are aiming to be 8 minutes and less. This is the time we want to. This is the response time we want to achieve it, and it's one of the goals in the vision. So the response time to be less than 8 minutes.
Okay, so the benchmark, what is the reference of this benchmark?
I don't have an answer for this question, sorry.
Any other question?
There's a quick question. I'm Dr. Sharif, consultant emergency medicine, National Guard Hospital. You said you are involving the private sector, private hospitals in your, whereas I understand the Red Crescent is a well-established in the Medina. So how the private sector is contributing to your Red Crescent? Whereas I know paramedics are well-versed in Medina, Red Crescent. So how their private sector is contributing to your targets?
This is a new initiative. We did it. We started with the Uhud sector. So we speak with the hospitals that they want to be in this initiative. They will provide an ambulance, and they will provide the driver and healthcare practitioner. And one of the employee in the Red Crescent, he will go to the hospital and he will work there as a normal ambulance from the Red Crescent. So the operator is still the Red Crescent. It's not the private hospital. They will just provide the ambulance, the driver, the equipment, and they will give us one extra response unit. And as I mentioned, with zero cost. Because some of the areas, they don't have an ambulance station, so they are covering more geographical area. So if you see, but we did not have the map for the ambulance stations. If you can see it, some of with the spread of the district, some of the area we don't have an ambulance. Still, we did not have an ambulance station there. So the hospital, if we have a station in the hospital, it will decrease the response time.
Yeah, can I give a comment? When we talk about time of the mission for ambulance, we divide it into various timing so that it gives a complete picture. For example, like if the ambulance is static, there's something called the roll-out time, where they start the engine and move. Because sometimes you may have to pick up some equipment and so on. So the moment you receive the call, activated, then there is something called the roll-out time. That's number one. Number two, response time means from where the patient, where the ambulance is to the place where the particular incident is. However, it doesn't cover the mission time. The mission time is actually a complete from the various timing to all the way back to the center where the treatment is given. Now, in our process of making the timing more meaningful, we divide into various timing and we determine where are we do what we call the gap analysis, where exactly the delay is. Sometimes when the driver is sitting somewhere having coffee, and then when the activation, he's getting ready and all, that also will give some time, including in the total mission time. Thank you.
Welcome. Actually, we divided the times for the whole case. Each call, we are dividing the time into 13 times. So we are dividing when the response time from the time they call until the ambulance reach to the area. We are measuring the time when he called and when the ambulance moved from the station, even if they are outside. The tablet itself, it's connected by the GPS. So when the ambulance will move, he will start to record the time when the ambulance moved. So all the times are recorded, and we are measuring all this, the moving time and when they received the call and when they moved, and etc.
Okay, thank you very much, Mustafa.
Welcome.
And for the question for the benchmark, so we'll refer this question for our Dr. Tasneem Al-Faredi. She's our next speaker. Actually, she's a consultant emergency medicine, disaster medicine, and emergency medical services from Brown University. And also she's the medical director of Red Crescent in Medina Al Munawwara. So stage is yours.
Okay, so there was a question about the benchmark of response time of 8 minutes. Actually, the response time, its definition to the emergency cases within 8 minutes. What do we mean by emergency cases? It's which triaged by our ProQA system, which is triage system for Echo and Delta, which is level 1 or level 2 mostly. So our goal in Saudi Arabia to reach those emergency cases of less than 8 minutes for 40% of the cases. So what is the benchmark? In USA and Australia, they are using of less than 90% of the cases. It should be reached within 8 minutes. Our goal to reach 90% of the cases in the future with the gathering of private sectors and more of ambulance units to achieve these numbers. I hope I answered the questions. I don't know what is the question. Okay. Right. Before I start, I promise you it will be a very light presentation. It will not be as crowded as a mass gathering. We will talk about the specialized care pathways in Saudi Red Crescent and outcomes toward Vision 2030. So basically, the role of Saudi Red Crescent Authority in mass gathering, it's very crucial and it's very important as they are the first responder of any patient seeks medical advice. especially during Hajj and Umrah, and especially in Medina. So the high patients and the challenges that we are facing, the high volume of patients in mass gathering, posing a significant challenges for emergency medical services. And that leads, because of the growing and diverse populations, increase the demand of healthcare services. And Medina considers as the second city in Saudi Arabia that have immigrants from Saudi Arabia or from outside Saudi Arabia. So that would need and demand more of health services. And the global destinations, it's 1 million of pilgrims and tourists annually came to Medina. And also the golden hour is not enough. Time-sensitive conditions like heart attack and strokes require more than just speed. They require a specialized and coordinated response. And in the Medina context, unique challenges of providing elite medical care, it's one of the world's most significant gathering places. So the overview of our specialized care pathway, that it's applied in calm ordinary days and also in the mass gathering days, we have 3 pathways: the STEMI pathway, the stroke pathway, and the trauma pathway. And the future would be more specialized care pathway coming soon. So depends on 3 things: early recognition. So once the medical team or the first medical responder team arrive to the patients, we need to recognize the issue. After that, we have the specialized response and the field diagnostic by well-trained paramedics. So this paradigm shift from the traditional way, if we transport the patient to the nearest hospital, into the specialized of transferring the patients to the nearest appropriate hospital. So this relies on what? Relies on advanced training of the paramedics, onboard medical technology and the telemedicine, seamless coordination with the receiving hospitals, and data-driven protocols and continuous improvement. So in brief, the pathways of the STEMI pathway, which is the for the patients with the heart attacks, if the patient's having a chest pain, he will call 997. The dispatcher will send a unit that is capable of dealing with the patients with the chest pain by doing an ECG. If they realize the patient is having STEMI, which it should be done within 10 minutes only, it will be transferring to a PCI capable hospital, which is, we have now more than 1 hospital in Medina that deals with the patients with STEMI. So it will be directed the patients from home into the cath lab. It will bypass the ER. This is the specialized pathways. And if we are talking about numbers, total patients in 2025 only, it was 259 until now, of course. And the average time from scene to cardiac catheterization lab was 40 minutes. And now we are more efficient than the guidelines, which is 90 to 120 minutes to reach the cath lab. And we are 40 minutes, so it's a huge difference in the number of minutes that will save the patients. Also, the stroke pathway, we are aiming to direct the patients to the real time and to the real place for intervention. So the paramedics will use a validated score, which is called FAST-ED. There is a lot of scores we can use to identify pre-hospital strokes, and this is one of them. It's FAST-ED. The same scenario of the STEMI patients. If the patient has a complaint of signs of a stroke, we will notify the hospital before the patients arrive, and the patient will be alerted as a stroke code at the hospital. The neurologist, the neurointerventionist will be ready, and the patients will be transported into the CT suite immediately. He will bypass ER also. If they rule out the intracranial hemorrhage, it will proceed by thrombectomy. And our aim here, it's thrombectomy or thrombolysis, but our main goal is to be thrombectomy for less complications of the patient. So what about the numbers? In 2025 only, we have 334 patients have been served in this specialized care pathway, and the average time from the scene into the CT suite was only 13 minutes. So what about the trauma pathway? It's, let's say it's still a growing pathway. We divided the patients also by triaging, something called national triaging system for a trauma. We divided the patients into coloring code, red code, yellow code, blue code, and white code. So if the patient is red code, our aim to transfer him to level 1 trauma center. And you know, this is the highest level of trauma center that have all these subspecialties to care with trauma patients. And the yellow code, which is less dangerous, it will go to the level 2 trauma centers. Also, these patients, if being recognized on the scene, it will be alerted the hospital before the patients arrive, and it will be shut down, the OR, the blood bank will be ready, the ER will be ready, the traumatologist, the orthopedic, the neurologist will be ready to receive these patients. So it is the same pathway. We alerted the hospital before the patients arrive. And I will not bother you with the details of the levels and the coloring coding of the patients, but to know there is something called national triaging system. And the main idea is the red code of the patients to be transferred to the level 1 trauma center. For example, the blue patients, it's important to mention that because there are some criteria of the patients that they need to go to the nearest hospital for resuscitation. For example, the unstable airways, the severe shock patients, or the traumatic arrest. I cannot bypass a hospital with those patients to reach the level 1 trauma centers. Our goal to arrive to a level 1 trauma center within 30 minutes. So the crowd medicine, even during the crowd and during the mass gathering, using those specialty care pathway, it will be a lot of benefits. First is efficiency. Rapidly locate, treat, and extract patients from dense crowd. And resource management, ensure specialized resources like cardiac unit are used only for the patients who need them most. And system resilience prevents local hospital from being overwhelmed by directing patients to the appropriate facility from the start. So what are the lessons we have learned from those implementation of this specialized care? Is the training. Continuous training ensures all personnel are equipped with the latest skill for effective emergency response, coordination with other hospitals, with other specialties, and optimization and awareness. Focusing on optimization and raising awareness leads to more efficient care pathways and better patients' outcome. Our strategies and our goals in Saudi Arabic Crescent is coming on the same way of 2030 visions, that to facilitate access to healthcare services and improve quality and efficiency. And Saudi Arabic Crescent Authority mandates to be a leader in this transformation by revolutionizing pre-hospital care, and also to deliver the care, the best health care to all people and by timely efficient. So the future direction and the Vision 2030, we want to expand those specialized pathway and to be integrated with the smart city technology and the streamlined communication, and to continuous updates and enhance operational effectiveness. In conclusion, this is a new era of pre-hospital care. Specialized care pathway are transforming Saudi Red Crescent Authority from transport services to a mobile healthcare provider. It's a cornerstone of achieving the vision of a 2030 healthcare ambition. It's proven to be highly effective in the unique context of a crowd medicine. And the result, saving more lives and building safer, healthier kingdom for all. Thank you. And if you have any question.
Thank you, Dr. Tasneem. There is any question for Dr. Tasneem? Okay.
Sorry, maybe I'm asking a bit too many questions, but
No,
anyway,
take your
I'm
time.
just very keen to know whether you have any initiative on digital transformation of ambulance service. Quite clearly, if you have a specialized ambulance, it will be very, very significant in its effect if you're able to send the data or the video or the picture from the ambulance or from the site to the emergency department so that you can have teleconsultation, make a medical directive. And this initiative we have already started in Malaysia, and it proved to be very effective for initial management in terms of bringing the care right to the incident site by teleconsultation and medical directive. Thank you.
You're welcome. So it's a very brilliant idea. And I think the EMS system is different from US and Europe. And our EMS system is integrated between US and Europe. US system is to pick up the patient and run to the hospital. But the European system is to treat the patients. They have CT ambulances, and they do thrombolysis for the patients on the scene. So our goal is to be mixed between them. We have sending picture of ECGs to the consultant and to the cardiology interventionist. We have a trial of telemedicine or video calls with the physician and the patients. But our goal to arrive the patients as early as possible to the nearest appropriate hospitals. So I think it's both is right, but it's a different system.
Okay, Dr. Tasneem, I have a question. Just to confirm, that means in any trauma patient that meet the criteria for trauma activation when they are boarded in the ambulance and the nearest hospital is not trauma center, they should handle the patient to this hospital or to bypass this hospital to the nearest trauma hospital?
So it depends on the condition of the patient. For example, if he is red code, that means he is a gunshot patient, or he has a spinal or a brain traumatic injury or low systolic blood pressure. Those patients are meeting the criteria for level 1 trauma center. We will bypass the hospital and we will reach the level 1 trauma center it should be within 30 minutes. If level 1 trauma center is not reachable within 30 minutes, I will go to the level 2 trauma center. What are the exceptions? I have to go to the nearest hospital if the patient's having traumatic arrest or airway condition, or he is in severe shock.
Okay, thank you, Dr. Tasneem. Any other question, Dr. Tasneem? Okay.
Thank you.
Our next speaker is Dr. Mohammed Ismail. He's a member of the Royal College of Surgeons in Pre-Hospital Care. He's the former director of the Air Ambulance Service in Saudi Red Crescent Authority. His presentation today will be about emergency strategy for crowd-related injury.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone. Inshallah, my presentation will be so simple, inshallah, and fast. First of all, I'm Mohammed Ismail, a physician in Red Crescent Authority. Today, lecture is going to be so fast and quick, inshallah, so we can catch up the lunch break. To start with, we already established the definition with my former colleagues about the what is the disaster. So we know what is disaster already. So we came across a word from the first beginning date about mass casualty, mass gathering. What is mass? How can we consider mass? This is the first question comes to my opinion. So as yesterday, I sat down with Dr. John and we were discussing about when to consider a mass. Well, the definition wasn't really easy. I went through a lot of references and they were saying whenever you have 1,000 and plus, some other references said 500 and plus, this is considered as a mass. So which one is it? So it depends on a lot of things before we consider the mass as a mass crowded. So they were saying that if you have 250 person in a confined place and something happened, this can be considered as a mass casualty equivalent to 100 to 1,500 if it's not well organized or well controlled. So it's not that. So they triggered people. So let's say that we are having a convention or a concert, that there are people, and the concert or the convention itself, it's emotional. For example, emotional like elections, like victory celebrations. This could be tense sometimes, and people can get really aggressive sometimes. It depends on the situation that's happening. On top of that, if it's a spiritual, like what we have in Hajj season, we consider that as a mass. So whenever we have a number, we have to have some organization happen to control these mass. On top of that, they were saying that if you have 2 to 3 person in a square meter, this is considered a mass. So my introduction is going to be about large crowd and public events such as sports, festivals, protests, concerts are prone to mass casualties caused by a stampede or as we call it overcrowding. Crowd medicine focuses on proactive strategies to predict behaviors, manage movements, and prevent panic, all what we call panic attack. Injuries in mass gathering ranges from minor cuts to life-threatening conditions requiring immediate first aid has to be done quickly. Effective planning and emergency response ensure safety, entry, environment, and exit for all participants. What are the types of mass casualties then? The stampedes and the compression. Whenever there is a mass casualties, the stampede has to be one of the things that could be happening, and the injuries comes after. The compression, we said excessive pressure causes suffocations to most of the people, fractures and head injuries. On top of that, in addition to that, other injuries could be possible. Fainting and fatigue, psychological or physical stresses leads to loss of consciousness, ventilation and rest are vitals. Falls and stampede and trampling. People may slip or be knocked down, resulting in fractures, sprains, or head traumas. Other injuries we consider, in addition to that, we consider as psychological effects of the mass itself, of the situation itself. To have a situation awareness about the mass casualties, psychological trauma, panic, and anxiety spreads rapidly. Whenever there is an incident, one guy who screams, the rest of the group will scream too. So triggering circulatory and respiratory disorders, sometimes people can start to have respiratory distress just with the name of having an event or let's say a scary situation. They might start, especially asthmatic people, they might trigger their asthma and start to have respiratory distress. Flying debris and sharp edges, collapsing structures or flying objects can cause cuts and eye injuries. Environmental conditions, rain, slippery surfaces, and extreme heat contributes to falls and heat exhaustions like what we have in Hajj sometimes. So what are the first aid strategies? First of all, we have to start with the first thing is assessment and triaging. So rapid assessment, color-coded, as my previous colleague mentioned, the definition of triage system, whatever you can use, the SALT, the jump start, the start triage. So whatever suits you and goes with your protocol, you can expedite the help of the injured people. So the color coding, and then the crowd dispersal and guidance, clear access routes, and direct people toward the safe zones, airway breathing and circulatory teams and issues that might have to ensure that everyone has, especially those who are affected or have been engaged with this kind of incident, to make sure that you have to have, first of all, to take care of them. Then we can go to the massive control of bleeding and then providing oxygen for those who in need. Response and support, emergency responses. Deploy medical team across the venue to ensure rapid response and conditional coverage. Use mobile equipment such as AEDs, oxygen supplies, and other life-saving devices to stabilize the critical cases, safely transport casualties to nearby hospitals or facilities, and distribute them based on the injury severity and their condition as well. Provide psychological first aid and claim victims, offer reassurance and direct them to the recovery areas, coordinate with the hospitals to prepare resources and ensure continuous communication. Coordination amongst the team. As we said, in disaster and mass gathering, always that this has to be collaborative teamwork. It's not a multidisciplinary, it's a multidisciplinary team. It's just not one man job. So effective coordination between medical security and administrative teams reduces chaos and improve response time. Medical teams, primary responders, specialized unit, and transport crew works in synergy. Security teams manage crowd flow, protect medical staff, and control panicked crowd. What we usually use in Saudi Arabia here, we are using the law enforcement together with the other non-law enforcement personnel. Notify the hospitals and distribute casualties based on medical needs while maintaining real-time communication. You know that life is all about timing. Rule of technology. Now we're talking, back in the days, we had limited resources to the technologies. Nowadays, technology is all over in our hand. So the advanced communication, smartphones, applications, and wireless network coordination, emergency response and locating victim. Geospatial and drones, GPS, and unmanned aerial vehicle that can be used, that they can deliver the defibrillators, blood products and supplies, and assess incident scenes. Sometimes we can use these, especially those included with the GIS, the Geographic Information System, as Dr. Abdullah was saying, Abdullah Hossawi, regarding they're using this kind of technology, especially in Haram, to know where are the places that needs to be intervened with, and to support and supply them with the needs if possible. Telehealth and remote monitoring, remote consultations and monitoring devices support field responders, and the GIS and digital mapping track resources, identify hotspots and plan efficient evacuation route. Robots and drones deploy medical supplies and perform reconnaissance in difficult to assess areas. Training and preparedness, building the capacity. Pre-incident training could be crucial to start to have a very obvious observation about any kind of mass gathering area. You have to train people. You don't want untrained men to be starting the events with unknown procedures, or what we call it improvised plans, this can be considered dangerous in case of mass gathering or incident or disaster. So trigger, triaging and mass casualties response require ongoing drills and pre-incident practice, first aid education, practicing, especially those who are participating in the mass gathering, they have to have at least minor or at least the preliminary informations about how to do this first aids. Technology efficiency, educate team. Whenever you have a chance to educate your team how to use the technology, just let them in. Drones, GIS, and the coordinated response, continuous evaluation. Whenever you have a plan, you have to run the continuous evaluation for your plans. This is to build your capacity and education and training with the people. So reviewing incident and exercise to refine protocols and update emergency plans. Integrated strategies, combine risk assessment, effective first aid, coordinated teams, modern technology, and continuous training to save lives. This was my last part of the lecture. I was about to talk because I'm a member of the Red Crescent, so I'm biased to my team. So I'd like to thank my colleague, Mr. Mustafa and Dr. Tasneem, for this information, for the lecture they did. And there are kind of questions I just forgot, you know, that I'm kind of old. Any questions?
Thank you, Dr. Mohammed. Thank you. Thank you for that great presentation. If there is any other questions?
Assalamu alaikum, Doctor. Very nice, excellent, and well prepared presentation. I want to ask, you spoke about drones.
Yes, sir.
Can we imagine that one day can come, we take the patient in a drone very fast from Mecca to Medina, for example?
Well, that could be a futuristic question. And the thing is, the drone, we don't want to take patients with the drone. We still have other facilities, but we can use the drone in other different aspects. Instead of using drone to transport patients, we can transport devices and medications to those who would need. This is number one. Number two, we can explore the area and the region. So we can tell, okay, this area, for example, needs more team to be covered with. But to take a patient from a place to a place, we still have the helicopters. So the helicopters is doing a good job right now.
It is time consuming, as you know, and it is large in size. And it will take a lot of time to prepare, and it needs some sort of mahbat, some sort to land on.
Exactly.
Some difficulties exist with helicopters.
Well, whatever applies to the drones can be applied to the helicopters a little bit, and instead of timing. Timing is good, but the thing is that you need a real trained personnel to activate or to fly the drones, especially with drones that can carry people. That's why we are reliable on the helicopters than the drones. The drone, you need really specialized, trained someone to fly that thing.
Let me tell you a very small piece of thing. I was in Hajj maybe 12 years ago. In the same bus when I was, there was an asthmatic woman. As soon as she smells the smokes of cigarette, she states asthmaticus. Can you imagine in Arafah, states asthmaticus? Yes. We were lucky. A health center was very nearby, and we took her immediately, carrying her from the bus. My question, are there any applications you intend in the future to distribute among those people gathered, crowdedness and the gathering is from different nationalities, different languages, different cultures? What is your impression? How can we improve?
Great. I'd like to announce something here in the Red Crescent that we're using right now. We're using multilingual program to translate the calls. For example, as the doctor said, if we have a bus with the different nationalities, someone called 997 right now, if you can consider, if you speak a special language, you can tell them right now. We can try that. Tell them that use your language, let's say German, for example, use German language. They will have immediate interaction or immediate translation, and they can respond to you as well. So you talk to them in their German, they will reply in German, and they will send it. Well, this was the part of the question that my colleague was asked, or Dr. Tasneem was saying. Nowadays, whenever we receive a call, we we immediately ask the ambulance to move without knowing what are the conditions. So in the route, they're going to the hospital, the patients, we will know the condition, and sometimes we cancel them in the route because we solve them. So let's say someone have been choking. So we will tell the patient on phone, the dispatch team, they will tell him, okay, you know what? Can you do this? Can you put your hand in his stomach? Can you push fast? And then some of the cases have been solved. They've been treated. So we call the ambulance team to be canceled en route. So we save time there. So, I mean, like Red Crescent is still promising. We're still having a lot of development going on.
Thank you.
Thank you.
Dr. Mohammed.
Thank you very much.
If there is any question for Dr. Mohammed? Okay. Now we'll conclude this session for one break, for 1 hour break. Lunch will be served about 1:30. We'll go break and get the lunch, and at 2 sharp we'll gather here again. Thank you.
Thank you very much.
ايش المشكله كانت؟ ايش تعطيكي؟
جربنا بالجهاز اللي جوا نفس الشيء طول معي دقت بالجهاز شكيت طلب من كذا
94
ها فتح. سوي بس تكبير الأول.
صغيرة لا غير العنوان خلص خلاص اشتغل العب اشتغل من عنده جهاز لا هنا بعد ما خلص مو بدي كتبتها هنا بس ما كتبت اسمه بس تكتب ها اشتغل الجهاز الثاني اشتغل الدفعة ها على العنوان كثير قلت لك بغير عنوان طيب انا ابغى الاسم موجود خلاص اخذ صح
يمديني أشغل المحاضرة. من هناك العرض ولا هنا في عرض بس ماني عارفة كيف أحطه. أوكي. رسمي يعني. لو كان أشوف إذا موجود. طب مصطفى يكلمه. كلمه. قول له إذا موجود تعال تصور. طيب. لا ما شفت الدرع. طيب خليني بس كذا أركز إيش مع التصوير. يمديني أجيبه دحين. طيب فين أطل هناك مثلا؟ وكان أيوة. من جد. والمسارات التخصصية التي يصل إليها الإسعافات من جد. So the ambulance will reach the patients with the chest pain. They receive the patient's call and they dispatch an ambulance to the area, and that will receive the ECG.
قال يلا 5 دقائق حتتفاجئ ايش في جوه. كويس شو؟ السلام عليكم ورحمة الله وبركاته. اليوم راح نتكلم عن توزيع الإسعافات ambulance location. هو فيديو؟ في صوت؟ تمام. We're going to talk about ambulance allocation and response and how we improved the response time to meet the Vision 2030 goals. So, when we are talking about the response time, as you can see in the schedule, you can see we improved the response time when we did that and that.
Hello? 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 Health risk assessment models for mass events. Today we will talk about the mass events assessment and healthcare system. طيب. دقيقة. Health risk assessment models for mass event. What are the programs that we are doing in Red Crescent Authority in Medina Munawwara? بس كده هكذا.
جاسم.
روح خذ لك سجارة. عندنا قاعات بس مو قاعات رئيسية الساعات عندنا رسوم. ماس جاثرينج والله ممكن يسوي فكرة. في دبلوم طب الحشو.
تحتاج جهاز.
يلا تقدم لي دكتور. جاهزين؟ طيب والله هو عشان يكسب وقت.
Assalamu alaikum. We'll start now. Our next speaker is Dr. Maid Al-Bidrani. He's associate professor and consultant of preventive medicine at the Department of Family Medicine at Taiba University. He will talk about risk stratification on mass gathering event.
Assalamu alaikum. Welcome everyone. Today I'm gonna present my lectures about the health risk assessment models for the mass events. So the outlines of my lecture is the introduction, health risk, the key health risk at the mass event, what is the health risk assessment, and overview of the risk assessment model, challenges, and best practices for the risk assessment. So mass gathering is any events that including religious or sporting events that have a lot of attendees. For example, it attracts thousands to millions of people, and there is a community connection and economic boost. So it can be considered as a unique public health risk, considering infectious agents, injuries, environmental threats, and strain on local health systems. So the health risk assessment can help us to anticipate, prevent, manage the risk to protect attendees and communities. So the health risk associated with mass gathering can be infectious agents like respiratory infections, foodborne and waterborne, like Salmonella, cholera, for example, vector-borne, and non-communicable like heat-related illnesses, and also the trauma and injuries, and also the environmental, poor sanitation, waste management, infrastructure overload, psychological stress, the psychosocial, for example, stress and anxiety, panic in crowded settings. So the principle of health risk assessment, the health risk assessment is a systematic approach or systematic process used to identify, analyze, evaluate health risk associated with the event, enabling the organizer to prioritize and manage those risks before, during, and after the mass gatherings. So it can help in the protection and safety if we apply it in the right direction. So the principle of risk assessment is the first step, risk identification by listing all potential threats, and then the risk analysis by calculating the likelihood and potential impact. They evaluate the likelihood of the risk and the potential impact. Then when we have this multiplication, we can arrange those risks and prioritize them. Then risk evaluation, the prioritization of the risk based on their severity and likelihood. The risk management, which is the planning of those risks based on the prioritization. So the health risk assessment can be integration with event planning. It should be part of the event planning that being early and integrated into all stage of event planning. So they usually involving multiple stakeholders, public health, emergency services, event organizer, local government, and usually these plans is under regular review and update as a new risk emerge or condition changes. So usually the general framework that used in the risk assessment WHO model. So they have WHO mass gathering health risk assessment tool. The idea behind the WHO mass gathering health risk assessment model is to guide the planner through identifying hazard, evaluating risk, and planning the mitigation. So, and it is a structural approach, and also it's flexible, so it's applicable to events of different scales and types. All hazard approach also consider both infectious and non-infectious risk. So one of the models that can be used. And also there is new models, it's called JIDDA model, which is Hajj specific, developed for Hajj pilgrims, but also can be applicable to different mass gathering. And also CDS risk assessment model, usually they use it for integrating the surveillance data with the scenario planning and emergency preparedness. The key elements of all models, they are similar. In hazard identification, they starting with hazard identification, and then they look for the vulnerability analysis. Who's the vulnerable people? If we have elderly, immunocompromised, children, and also they looking for, from the perspective of the exposure science, which they call it exposure assessment, they look for how likely the exposure and what condition can enhancing that risk. For example, if we have crowd density, so here the vulnerability become for the spreading of infectious agent. If there is hot weather, so the hot heat stress then can be also the condition can enhancing the risk. So then they look also the consequence analysis by evaluating the impact, how much the number of people can be affected, and also they evaluate even the health system. They have structural model to evaluate the health system to see if there is a strain or if the health system is ready for the surge or can deal with this can deal with the surge when it happened or no. The steps in the health risk assessment model of event, the pre-event risk profiling, which is including identifying the feature of the event, the type, location, expected crowd, and seasons. Those are very important factors. And also the data collection and stakeholder engagement. They usually preparing the data collector teams for making not just surveillance for infectious agent, also they make kind of surveillance, even the injuries, illnesses, other illnesses that can be considered in the future planning. Also, they incorporate also the scenario planning and modeling, then risk prioritization, and the planning also contain the mitigation planning. So they have anticipate plan, the extra medical station, if there is a vaccination clinic needed, crowd control, all those kind of stuff, it can be considered. Then the continuous monitoring and real-time data, usually as a part of risk assessment model. So the good things about those risk assessment model, they can be adaptable to different contexts. They can be applied for urban, also they can be applying for the rural area with low and high resources setting. All of those the models can be adaptable to them. So the challenges, usually data collection, data limitation, and uncertainties. Usually sometimes the dynamic and evolving risk is unacceptable, unexpectable risk when it happens. So can be challenging for this risk assessment model. Multi-sectorial coordination, it requires, depends on the cooperation between the different sectors, and also the ethical sometimes and privacy concern. It depends on the, the laws that sometimes collecting and sharing the health data, it's required for this model, and sometimes can be challenging from the ethical perspective. Thank you very much, and this is my references. And next one.
Thank you, Dr. Moyed, for your presentation. Is there is any question for Dr. Moyed? Our next speaker is Dr. Abdullah Al-Hawsawi. He's the head of Information and Scientific Service Department, custodian of the two Holy Mosque Institution for Hajj and Umrah Research Center. Also, he's the head of crowd unit at Imam Al-Qura University at Makkah Al-Mukarramah. Today, he will present about the physiological of mass gathering.
Assalamu alaikum wa rahmatullahi wa barakatuh. So, my topic is supposed to be about psychologist theory of the crowd management related to what I have present in the morning. Sometimes you don't trust the technology. So I made my file, I uploaded to my OneDrives, and so the job is finished. Then when I came here to Medina, we tried to download our file several times, then we couldn't. But I'm expert in crowd fidging. So we are going to go through all the technology that could be applied in crowd managing, crowd dynamic, crowd movement. So there is more many technical that we have used and applied during Hajj. So when in computer fidging, as you can see in Hajj, this video with this information, it's not supporting anything. We cannot help this information. We can these videos will not help us to take any decision. Okay. This information is not going to help us with nothing while we are controlling or managing or doing so and so. This kind of information, when we translate it with the power of AI, so it can be used to control people. When risk goes up, then we can control it. Regarding which is, I'm going to compare with I have present in the morning. There is a density map. So the density map, there is the density map show us how we can control between the camera, which is far away from the local movement of those people. So this camera can help us, which is, when the density has increased, so we can take decisions, say, okay, close the door from the entrance so people, they can take another path and goes. This is also another way that we can detect with the AI, the movement direction. If the hazard has been increased, then we can say, hey, don't go that direction. We can detect it from the system, and then you can send someone, which is, to direct this person to the right path. Here is also, we can show you the power of AI. Sometimes the operation time, it's not suiting the time or the place where you go. Then if we show those people with the risk that has been increased in this area, with the level of the density, then they can maybe reschedule their watching this place or cleaning this area. Here is also, we can show you the power of our system, that he can detect the hazards from the TV that we take, the video we extract from the TV. So this is how our team show their capability at the expert in this area. Here is also another way. You can see the increase of the risk has been increased on these corridors. We show this just to reduce the risk. Here is also another way of showing the merging camera. Maybe a couple of years ago, you can most of the cars has been developed with maybe 5 to 6, 7 cameras. So how you can integrate these cameras together and put it in one view? Then you can see what's behind, what's in your left, what is in your right, one in your in front. So by doing this or combining these cameras together, you can see exactly what's behind you. Here is also, this is from one of our projects during extension the matafs, which shows also the speed of those people while they are doing their ritual tawaf. Here is also detecting some people from the crowds. Here is also the accuracy level of these systems. You see we coverage around 97%. And another also counting in King Fahd exit or entrance. We count people while they are going inside and coming from Haram. And the accuracy of the system was 96. And here's also we can see, by doing this, we can identify the bath for those people, how they go, from which bus they go. So what we putting this data in our history, then we can return back to those. We know every Saturday or every Sunday there is a movement increase on this area. So you can send your mail loading people to go there and manage the flood or the traffic of those people. Here is also you can see where is the most traffic used in after prayer in Ramadan. So after doing their after praying the Taraweeh and after doing Tahajjud, so we know exactly which bath people use, which bath they don't use. So by doing that, you can manage also your management plus. In this way, we can, in these pictures, it shows us the level of the density has been increased in 1 meter area. So we have average four person, which is in peak time or in high level, it should be 4 people in one area. So you can see maybe in Haram sometime in days of 27 of Ramadan or 23 of Ramadan, this number is not valid. We can't say it, which is, it goes to 7, it goes to 9. There is some article they have found, which is, it increased to 7 or 9 people or person in 1 meter. So you can imagine how this level goes. So if we have these systems, it can reduce the risk of death or fainting people or being injured. So our work is it's before our work is before you. We don't want, we are all saving the injured of the people. Some they do it in hospital, but for us, we are try to manage for those people to go and come back with their, we put their safety and safe and going home back to their family is our main concept. Here is another project which show you also how we detect also number of people while they are moving from Arafat to Muzdalifah, then while they are throwing their stone in Jisr al-Jamarat. Here is which is background subtractions, which show you the accuracy of your systems. The white one with the black dots, it show you the number, and the other one, which is with the red and would show you also another filtering. So if we miss count some of those, so you can detect the point of those people are moving, then you can recount them again. So this is the way how we being checked. We have count every person in this area. Here is also another bath from different dimension or from different location. Here is also from different location, showing you that we have count most of those people, they are going to the Umrah. And modeling and simulation, which is here also you can see some videos. We have prepared these videos while I was doing my PhD, which show you the simulation, the power of the simulation using the 3D. We were at that time working to find the best simulation that can be used for from everyone. Because we know the simulation, which is to buy license, it costs around 1 million or 100K, which is a lot of the people, which is a lot of money for those people, which is hard for them to buy all these kind of tools, and hard also if you are not expert on it. It's hard for you, which is to spend 100K and you don't know how to use it. We work on this project. Maybe we are 5 PhD student. We create this simulation, which is based on just using some icons, which is and applied to your environment that you want to design. So it shows you, which is how you can build an environment area, and with the result, it will show you also provide you more result about your scenarios. It's easy to put gate, easy to put obstacles, easy to open door, to close doors, which is based in science. And not only that, but also it gives you which way people use while we are doing some scenario, evacuating those people from different environment or indoor environment. Here is which is it show you also how we generate people based on their speed, based on their density level, which can show you on in the couple of minutes. You can see some trajectory, show those people using these bath, which is not evacuate themselves. You can repeat several times. Here we show you most bath people use in their environment, which door they use exactly while you are doing some testing before you design your building. So it shows you what the people use to evacuate from this location or from this location. Maybe you can move, you can put your doors based on the scientific way, which is sometimes you put your exit in a place where people, when they stand up, they go to the wrong directions. So based on the majority, we try, which is to give you a suggestion while you are doing your stadium, especially in indoors, we tell you, okay, take 6 meters and put it there. Most the people based in majority, they use this direction to evacuate themselves in this building. There is some criteria that you have to put on the model. So it show you exactly where it should be, from where to where you should put your doors, because all of the majority, they use this area to follow. As I show you in the couples, in my presentation in the morning, I have showing you that level of the density is important, using simulation also, as well as one of the bar to measure that density in there. Here is also another scenario which show you if we have fire or smoke in that area. So we put, which is based on the standards, which is if this smoke has occurred in this area, you have to evacuate those people within certain time. We start testing this time in our simulation to see if it's fitting the standard of evacuation for those people in that building or not. So based on that, we have generate different scenario, different system, just to test different aspects. Here is also in the last video, you can see the level of the how if it was in a tower, which is hard for us to go that tower. So we have to know those people where they should go, how they use the exit door, maybe in 10 levels, and see their path and their speed, also how much time they take to go until to the first floor or second floor. So based on that, we gave these recommendations. We use this trajectory to measure the distance, to find behavior of those people, distance, speed, behavior, all this, it gave, we extracted from this path. So time, how those time take, but that's the reason why we put them in different color, because we know those, they came from this floor and others, they came from those floor, just for evaluating our systems. And here is also another one which show you the power of the simulation in Haram. This was one of our project that we did it. Another way of the simulation as well. Also, this is, it show you the train station. One of the train station in Mina and Arafat in Muzdalifah, they have the same layout. So we try to find the time and speed and density of those people while they are doing their ritual at that area. Here is one of the corridors, Suq al-Arab, which is one path for those people they use also to move from their tent to go and throw their stones in Mina. So, and here is also another way we speed this one and see their pathway. And here is another one. Also, you can see in one of the how we use the 3D and extract those people and see their behavior inside. Sometimes we use the VR, which is to go inside the train station in which is in VR systems to see exactly how those behave, train them inside. So this is of the way that how we train also people in outside. Here is also another way where we use some scenario to do it in Al Masjid Al Haram. How people they move from they enter to do tawaf, then they go to sa'i until they finish. I can show the desk, the dashboard that we create. Here is, I think. Here is the dashboard. I thought that it was working here. So it shows you exactly the movement of those people while they move and increasing the these graphics. Here you can see also another, while we are using the which is Arabat or wheelchair in Haram. So we create this scenario to improve the wheelchairs scenario while you are tracking them, seeing, showing you some scenario, showing you some information about your plan before it was executed. So testing. Here is also another one for Al-Masjid Al-Nabawi Al-Sharif. It show you here also how we measure all this movement of those people from location to another, testing their performance, testing their time spent, their time spent, density. So to manage or to give a proof for each scenario or plans, we have to go through these kind of steps before it was approved. I've been, which is, as a consult in many projects. So to give them my result, it has to pass from these scenarios. We put several parameters, which is, if it pass here, so that means people, they can pass also in the real time. We tried not to put too much people. We said, okay, go with the 70% of the capacity of that location and test it here. If it's done, then we apply it there, test it again in the field, finding where the problem is, taking that notes and again take it, apply it to our modeling plan and redo it again until we go, or until we finally approve that level, or we can reduce the capacity of that, the capacity of the people in that area until we get it fit. Human experiment. I have shown you maybe some in my morning presentations. What is the relation between the layout or the environment itself and based in engineering? Sometimes the layout of your plan is not fitting the way that how people they can fast evacuate. You can see from different direction, maybe they have one exit, so the level of the density increase on that path. So you have to manage to open another door or find a way. We have tested maybe more than 18 angles, which is, with different directions, to find out the relation, which one is fitting while we are evacuating the peoples, to know exactly what we are doing before if, la samahallah, something happened or something's beyond our scope, which is, until the person goes to the hospitals. Here is also another one, which is I have, I don't know, in the morning, it doesn't work. It show you here we are to find the competitors and competition that happens here. Our key parameters is time speed for evacuating those people. With the evacuation, some studies said if you put these obstacles in front of that doors, so it will reduce the time, so for the evacuating. So we test it, but it's hard to do it with the people, with the human. So we do it with ant, we do it with mice, we do it with so many legal ways, which is just to save human life. Mobile app, how also mobile app will be used in crowd management, like Manasik, like Tafweej. All these smart app, it helps us to manage, to have a reservation before you come in. So I know at that time, at that location, I have people, when they will arrive at that time. So I will, at that time, being sure their space is ready, your surface is ready, everything is being fine. So when those people, because I know I put it in schedules, as well as I have getting many questions, which is, so what about if people, they're doing their reservation and they didn't come at that time? We apply at that location what is called location area. So whenever we know, so you go to Mecca, you have, you do your reservation when you go to Mecca region, so Haram region. So based on the app that it was in your bucket, we will detect your location. So you are in this area, so we know those people are close to our time. They will come and do, and we will serve them. So what about those people? They are far away. So the system also, or the app will show you, okay, you have 20% of those people are far away. Maybe one in Jeddah, one in Riyadh, one in different location, which is it takes 2-3 hours to come. So we know those numbers are not going to be in our location. So what we do, we open another, which is opening ticket, which is if you want to reserve, if you want, which is because the space is you are in that area, and it will be your options to reserve and have your service. Digital twin is one of the which is most technique that has been developed and used also to know the location of those group of people. You have seen maybe in this map, you have different group of people. Those are representing different nationalities with their numbers, with their food, with their path of coming back. What about those people if I want to move them for next year from this location to another location based on their request? Because we know we have sometimes maybe more than 100, 100, like let's say more than 200K for Malaysian people. We have maybe 220 for Nigerian group. We have 80K for Pakistan's. We have around which countries also they have higher number? Turkish. They have around 120. So those group of people, they move based on their religions, based on what they believe, based on group. Also, they come from different states. So all this, we try to take their behavior and we try to locate them in where they can go to their housing place, going to Medina, or going to Arafah, Muzdalifah, and Mina for their schedules to throw the stones and come back. So by putting here, moving them from location to location with all the elements that we put without missing any element, because we are testing it in other way. This is also a 3D model with the bridge, which is just to enhance and find the safe of the people while they are doing their ritual at that area. Here is also, this is gaming immersive technology. How we use this game to train people with their duty in Hajj. So it's hard to bring more than let's say for soldiers, we have around 100K. They come and they serve, but most of them, sometimes it's the first time they came to this area or this place. So we show them this kind of videos for training them. Knowledge management. This is one of the what happened after Corona. I think most the ministries has been affected by that. Most of those expertise has been retired. So when the next level come after COVID-19, you see most of the operation has been changed. So what is the way that how we can extract this information or getting some information from those people they have more experience? We have, which is RAMS, which is based on knowledge management evaluating tool. Sometimes in you were in field, we have the way sometimes, which is for me, I can say here in this room we have 20% of the capacity. But if someone here come which is not expert, or someone has he said it's almost 35%, 90%. So for me, as the expert, they will take all my information record based on the data. So sometimes, so we keep it based on the area itself. So when the new person come to that area, he knows exactly how to manage level of those people, not to increase, not to be increased, which is, to let people go to the fate or injured. This example you can apply it in corridors while people are going to Haram, coming back from Haram. We know many people, they come there, but they cannot expect, or they don't have the level of that density on that location. So we start teaching those people based on this until he get to know what to do, what time they will close the street, what time they have to take a decisions. We don't want to go, which is, until 19%, which is, for that street to be closed. No, we go 50%, 45%. Sometimes when you go to Haram, now, which is to close Haram, they put it as 50%. If the area of the 50% in Haram, so they will close it. So sometimes you go, there is empty, there is a lot of space. Why they didn't let me in? So now, which is on the maximum spent is 50% of the Haram, just to save of those people while they are there. Here is also another way with the counting, another model, which is they count those people before in corridors and apply it, getting their knowledge, those people before they retire. Here is also some example. We can put it in our database and use it later on. Here, emotional system, where we also testing now people, they are happy, they are injured, there is some relation. In these figures, you can see people are happy, are not happy, and relation between you are, if you were like, over expectation when you go there, and sometimes which is, over expectation when you go some places and you don't like that places, but you said I was muhbat, so I over expectation with joy, with the joy, so it gives you disappointed based on some relation that we are testing here. So, but here we apply it in a social environment, which is there is many application now in tutors. We testing all this to find out all those people are happy, not happy, they are enjoy, they are not. And here is also even emoji. We test emoji between Ramadan and Hajj and see people they like or they don't like. So all these after doing Hajj or doing their rituals, we test this information to see how the service, how it was good or bad. This is the end of my talk. Thank you so much again.
Thank you, Dr. Abdullah, for this informative slides, actually. If there is any question for Dr. Abdullah? Our final speaker is Dr. Abdurrahman Bashauri. He's the supervisor of the Safety, Emergency, and Disaster Research Unit. Also, is a crowd management consultant at the custodian of the two Holy Mosque Institution for Hajj and Umrah at Al-Qura University. We'll talk about the humanizing the holy site as an approach to enhancing crowd safety and health.
Assalamu alaikum, welcome again. And it's my pleasure and honor to present a talk about humanizing the holy sites as an approach to enhance crowd safety and health. First of all, I'm going to give you an overview and then tangible value of this study and how the pedestrian path in holy sites looks like, and some statistical result from the questionnaire and some field monitoring from the observation tool. And at the end, I'm going to give you some recommendations. First of all, as we know, humanizing city is an emerging concept in the field of urban planning. It focuses on transforming urban environment into human-friendly aspects that offer comfort and meet the health, social, psychological, and cultural needs of masses. The main value of this study is facilitating the performance of religions, rituals, enhance safety and security, leverage modern technology in crowd management, and also preserve the spiritual and architectural character of the area. And this is part of the pedestrian path in holy sites. It's just one part. And it's within the holy sites, Mina and Muzdalifah and Arafat constitute essential infrastructure that facilitates the movement of pilgrims and organizes crowd flow during the performance of Hajj rituals. And this is some data from demographic result. As we see, a male walking and using the pedestrian, which is for long distance between performance the rituals between Arafat and Mina and Muzdalifah, and most of the people under the 45 years old. And some result about the walking experience, as we can see, majority of them was not that satisfied. And in terms of the difficulties they face, and as we can say, because most of the people say it's long distance, and some suggested overcrowding and lack of rest area and lack of shadow. And also some of them say it's high temperatures, especially in daytime, and barriers and obstacles, and insufficient of site guidance and limited support services. In terms of the enhanced humility or tranquility, and we can see not that satisfied people. In terms of enhance the spiritual aspect, and majority was suggesting remembrance by the out speakers, and also wallpapers, and also providing space for the contemplation and rest, and others suggested soothing visual environment and spiritual awareness messages. In terms of the cleanliness, and we can see majority was unsatisfied. So what we found out from the observation tool, one of them, overcrowding on some pedestrian paths during the peak times, particularly during the mass transit and mass gatherings. A lack of umbrellas on the some pedestrian paths can lead to fatigue and sunstroke during the scorching midnight or midday sun. Poor ventilation within the closed baths. A lack of sitting and rest areas. A lack of support services such as first aid stations. A lack of guidance and awareness signs. A lack of assistive devices. The absence of an efficient waste management system. So what we recommended, first of all, green manufacturing using eco-friendly materials and products. Mist calling, installing outdoor area cooling system which producing a cold mist that lower air temperature. Flexible rubberized pathways, improving the walking comfort and reducing the pressure on feet and ankles, and observing the physical stress. Universal accessibility, like ensuring full accessibility for people with the disability. Emergency routes, which can we use it, okay, specifically lands through which emergency vehicles such as ambulances and civil defense units can respond fast to accidents. Industrial waste compactor, reducing the collection and the transformation efforts, and facilities hygienic disposal, and prevent unpleasant odors. Smart guidance signature, installing integrated signage system. Integrated service such as lost person guidance, mobile clinics or for heat stroke and exhaustion treatment. Tree planting along the pedestrian roads. Solar energy using for lighting bulbs for maintain pollution-free environment. Urban square for designing open area space. Alternative use, we can use it also outside of the pilgrimage season, such as sport events, social festival, and others. In conclusion, crowd medicine is not merely about managing numbers of treatment medical cases. It's about embracing the human being in moments of vulnerability, fatigue, and spiritual reflection. The most important is to ensure that every step taken within the sacred sites is safe, comfortable, and filled with the tranquility. Thank you so much.
Thank you very much. Any question, please? Huh? Yeah? You want someone? Hi. السلام عليكم. طيب الله يعطيكم العافية. Any question, please, for the previous speakers? Any comment, any suggestion, anything? Any gift, any money, please? ها؟ في أحد يتكلم ورا كأني سمعت أحد. الله يسعدك، شكرا. طيب يعطيكم العافية. Thank you very much. طبعا tomorrow still we have Zoom, the third day, but it will be on Zoom. There will be a link for all of you. Okay? طبعا لا تجون هنا. It will be online. Okay? وشكرا جزيلا لكم، وإن شاء الله نشوفكم في المرات القادمة. وإذا في أي اقتراحات أو أي نقد أو أي تعليق أو أي شيء، احنا we are very open for any suggestion. والله جد. بالعكس احنا نتعلم من الأخطاء وكل شيء، وكل مرة إن شاء الله يكون أحسن من اللي قبل. تمام؟ الله يسعدكم و thank you very much all. Thank you for our speakers from Malaysia, from Qatar, from USA, Prof. John, Prof. Phillips, and Dr. Dato. Thank you very much. Assalamu alaikum wa rahmatullah.